hand over to Professor Reid to open the event.
Thanks, James, and good morning, everybody. Great to see you on a Saturday morning. So I'll do a brief introduction because I think we've got introductions as we go through the meeting. But firstly, my name is Malcolm Reid and I'm Dean of Brighton and Sussex Medical School, and I've been here for 6 years now. And the Oncology, Haematology and Palliative Medicine Society is a relatively new society, but it certainly got off to a cracking start, being very active and organising some excellent events. And this is the biggest one to date, and I think looks really interesting and exciting. And I'm delighted, absolutely delighted, that it's in partnership with the Sussex Cancer Fund, who do a lot to support cancer research in the area, and but particularly in the medical school. And I'm looking forward to hearing updates from the researchers later on in the programme. And that follows what I think will be outstanding presentations from David Chang on pancreatic cancer, and our own Melanie Flint looking at breast cancer and stress, and followed by a really interesting session with Richard and Anna. So I think that this is going to be a wonderful programme. It's very close to my heart as a breast cancer surgeon, and I had cause to be looking back at my previous logbook the other day, and it reminded me that I'd treated 2,500 people with breast cancer and about 400 or 500 with soft tissue sarcoma. And so a career in oncology certainly can give you a wide range of experience. And I go back far enough to have started my training where we covered quite a wide range of different cancers. So all the topics this morning are interesting to me, and in particular admiration of David, because pancreatic surgery is about as challenging as it gets for your typical GI cancer surgeon. And Melanie's talking about breast cancer and stress, but the most stressful things you can come across as a surgeon are when an operation like a pancreatic procedure goes wrong, and the days, weeks of stress that causes, mostly to the patient, of course, but it's also pretty challenging for the surgical team when these things happen. So I don't think David will be talking about this morning, but I just wanted to reach out and share, in my case, memories of those kind of experiences. There are no housekeeping notes, obviously, but if you do hear a fire alarm, please respond to it, because it's certainly nothing to do with this meeting. And I'm hoping you know where your toilets and other facilities are, and obviously feel free to use them at any time. And with that, I think we should press on, and I invite David to speak to us on what is cancer and specifically Precision-Panc. Thanks very much, David.
Thanks very much, Professor Reid. Thanks for the kind invitation, and really honored and happy to be here this morning. Yes, pancreas surgery could be stressful at times, especially with audible suction is going on. However, I think, surgical technique as well as our colleagues in anesthesia in ICU has made the surgery a lot much safer as compared to 20 or 30 years ago. So hopefully we are performing surgery much safer than we are. So James, do you mind share the slides?
Is that working for everyone?
Yes, that's perfect.
Brilliant.
Okay, well, thanks again. So I've been tasked to probably give everyone just a very bit of brief background on what cancer is. And also, I'm apart from being a consultant surgeon, I'm also a translational cancer researcher that mainly concentrating on looking for novel therapeutic strategies for pancreas cancer, and also co-lead this Pain UK initiative called Precision-Panc, which I'll come to in the second part of the talk. And the aim of that is to accelerate therapeutic discoveries for this deadly cancer. So without any further delay, James, do you mind just roll through the slides, please? So we'll just go through a little bit of a few cartoon slides of what cancer is. So next slide, please, James. So cancer really is a disease of the cells. So that's a bit of a cartoonish painting of what normal cell looks like. And you can see they're actually quite uniform. They grow smoothly, and they all looks probably fairly similar to each other, and actually looks quite normal. However, next slide, please. And as we grow, the normal cell divide and grow, and also develop and also repair, because as we age, we need to replace our cells by growing more stem cells, and the old ones will be, obviously taken away or either passed out. And it really is almost like a power of two divisions. So one cell divided into 2, and then 4 and 8, and so on and so forth. Next slide, please. And in fact, I guess, since the beginning of this talk, our body has actually made, these are probably approximate numbers, 140 million red blood cells, and about 35 million gut cells, and also 40,000 of skin cells. So these are just a normal day-to-day and everything that we do as we are being alive. Next slide, please. However, during the normal cell replication or normal cell division, there's genetic instruction that normally tells the cells when to actually start to divide and also when to stop dividing. However, these instructions of telling cells to move or not to move can sometimes go wrong. And what will happen, you can see there on the cartoon on the right-hand side, is that a tumor is starting to form. And then it's actually starting to form without the right instruction of when to start dividing or when not to divide. Next slide, please. So these are probably some of the key causes that can cause cancer, and also basically cause error in the replication, also in the DNA, which is the genetic code that every single one of our cells actually carries. This can happen during just like normal aging. So as we grow old, as we build up over time, this genetic code or this code instruction to go divide and not to divide can sometimes go wrong. Again, just with the normal cell activities, sometimes the signal can actually be constantly, the dividing signal can be constantly activated, or the signal that to say the cell you should stop dividing, that has actually been blocked. Also, sometimes it can be genes that can be passed down from family, as we all know that we carry a copy of our DNA from our father, and another copy from our mother. And sometimes these the gene that causes the error or the error messages when to divide and when not to divide can be faulty. And probably one of the most sort of well-known or famous gene for this would be the BRCA1 or BRCA2 genes, where we know the carriers of those individuals, they are more predisposed to other cancer types such as breast, ovarian, even pancreas, and also prostate as well. And another cause that can cause, the error in the DNA replication is lifestyles, such as all the naughty and fun things we do, like smoking, drinking, and also even just sunlight that can cause skin cancer, such as melanoma. However, there's also certain virus types that can also cause the error in the signaling of cell replication. So viruses such as human papilloma virus can cause cervical cancer, so cancer of the cervix, or hepatitis virus, which is a lot more in the Far East, that can cause liver cancer. And also certain bacteria as well, such as Helicobacter pylori, that can also predispose individual to gastric stomach cancer as well. Next slide, please. So there are probably 10 sort of key ways that the cancer cell can differ from a normal healthy cell that knows, when to start and when not to start, when to stop replicating and dividing. So this includes unstable, also damaged DNA, and then they have the autonomous signal to grow without being told to do so. And then also they have this survival advantage that they can just continue to multiply forever. And the other thing what the cancer cell also does is that it actually hijacks the inflammation. So they can turn the normal immune response from the body into something that is a chronic, unfavorable immune response in the within the microenvironment, also around the cancer cell. And also these cells that live forever, they do not self-destruct. And it also actually attracts the growth of new blood vessels so that they can get nutrients to continue to grow. And what it also does, the cancer cell, it actually invades not just the tissue within its organ, but it also invades other tissue that's around the organ, such as major blood vessels around certain organs. And the other thing that I mentioned before about the immune system, sometimes the cancer can be really smart, because every day our immune system actually goes and mop up any sort of cells that's been produced in error. However, the immune cell sometimes can actually evade or hide from our immune system or immune surveillance. The other thing that cancer cell can do is that it can actually reprogram the energy use, i.e. they can go from one particular source of energy to another source of energy, or one particular amino acid to the other amino acid, to actually facilitate its own survival advantage. And something else also quite smart, what the cancer cell does is it actually evolves. So sometimes it can actually evolve from a less aggressive cancer molecular subtype, that is, into something that is more aggressive, or sometimes it can even transdifferentiate its lineage. Let's say going from something that looks more like an adenoid cancer to something more like a squamous type of cancer. So as you can see there, that cancer can actually do a lot of things that they can actually be quite smart and quite difficult for us to treat. Next slide, please. So, however, research is actually making a change. So for people that survive with cancer for 10 years or more, as you can see on the top right-hand side there, there's actually doubled since the 1970s, and many of this is thanks to the research that the community has made in UK and around the world. So as you can see on the survival sort of percentage on the left-hand side there are many different cancer types that you can see that there has been a very good improvement in the overall survival. However, as you can see, there's one really flat line on the bottom, and that's actually pancreas cancer. So pancreas cancer unfortunately has not enjoyed the or has not reaped the benefit as yet, I should say as yet, for all the research that's been put in over the last decades. But I think hopefully something big is going to be around the corner. Next slide, please, James. So not sure if many of you actually know that pancreas cancer is predicted to going to be the second highest cause of cancer mortality, within the next 5 years, really. This projection was done back in 2014. However, it's close. I mean, we're in 2021 now, that it was originally predicted to overtake large bowel cancer as being the second most, but I think it's actually not far behind. So these are the data from the USA. However, other Western countries are actually not far, because pancreas is already overtaking the mortality of breast cancer, and it will probably overtake large bowel in the next 2 or 3 years, and only just behind lung at the moment. Next, please. Next slide, please. So as I say, it's a cancer with pretty poor outlook. So if we were to just by random diagnose 100 patients today, and 7 of them will still only be alive in 5 years' time, and then on the average survival is only about 6 months. The majority of patients unfortunately do succumb to the disease within the year. Now, still thus far, surgery is the only chance of cure. However, most of the patients actually present in the more advanced stage, either they've invading onto the blood vessels or other vital organs around the pancreas, or the disease has actually moved elsewhere, such as to the liver, to the lung, that surgery is actually no longer possible. And even with patients that undergo surgery and also chemotherapy after surgery, the 5-year survival is, about 35% at best, as disease unfortunately do recur even after a so-called successful treatment. Unfortunately, sort of novel treatment development has been quite challenging over the last decades. However, one thing we do know is that, I should say, that's not through the lack of clinical trials. We have done a lot of clinical trials. However, it does, it does, take a bit of time, for the trial to come through. However, we start to learn a little bit more, which I'll come to a little bit later, on why we think some of the trials might not be successful. However, there is one phenomenon that we do see, though, albeit the percentage are small, and that is, any sort of cancer drugs or any regimens that we give to the patient, there's always a small proportion of patient who does derive a significant response. However, the problem with it is, I guess, which is also the art of precision medicine, is we don't so far have a very good grasp or idea of which patient these are going to be until we actually test these drugs on the patient. Next slide, please. So just a bit of a cartoon on what what has changed on how we view cancer over the last decade. So in the old days, this is how we used to see cancer. So cancer is actually been seen as based on the anatomical organ of origin. So each cancer type, majority has been seen as reported being the same, like he's assessing pancreas cancer. Most likely the reports that we get back from the pathologist is this is pancreas, ductal adenocarcinoma, not otherwise specified. However, we do know as we increase our magnification of our microscopy to light microscopy, and more recently, we do have the resolution down to every single nucleic acid base of every DNA and RNA. And we start to see more and more different subtypes of cancer, not just pancreas, but also other cancer types as well. And this is also because clinically we do see not all cancers that they may look similar under the microscope, but they do actually behave quite differently, not just in terms of the outcome, i.e. the prognosis, but also to their response to the drugs that we give. So i.e. there's really not a one-size-fits-all a solution when it comes to cancer types. And this is probably best demonstrated with a lot of research is done with breast cancer, which is probably at least 10, 20, 30 years ahead of where we are understanding pancreas at the moment. But we do know certain subtypes that contains the estrogen receptors that respond to anti-estrogen treatments, or certain subtypes that harbors a particular gene amplification that respond to Herceptin, for example. And this is gradually being rolled out to quite a few cancer types that has enjoyed quite a lot of this so-called biomarker of treatment response selection against drug type of success, especially as well can see lung cancer and some in ovarian and also melanoma as well. However, we still have a lot of work to do in terms of pancreas cancer. Next, please. And this is what actually brought us together to bring the stakeholders that are interested in the research and also treatment in pancreas cancer together. So it's a therapeutic development platform that's majority funded by Cancer Research UK and was started back in 2017. So the idea behind it is so that we will bring the three major pillars of precision medicine or therapeutic development together. So they are indicated on the top right-hand side there being the discovery pillar, the preclinical development pillar, and also the clinical development pillar. So the idea is actually to bring these three areas of research as close together as possible so that we can rapidly translate what we find in the discovery world, i.e. more blue sky thinking research to work out what is the pathophysiology of the molecular pathology, biology and pathology, what could be the potential vulnerable target of a specific cancer subtype, and work out what sort of drug that might actually work for this. And then we take that onto the bench in the research lab and try to test out hypotheses using cell lines or xenograft or genetic engineered mouse models, and really to work out to see if our hypothesis to this drug combination is correct or not. And if they were, then we drive this concept into the clinic, where's the clinical development, the bottom left-hand side there, so that we can do appropriately designed and selected clinical trials for these patients. And then of course, all these patients, their genome and transcriptome will be sequenced, or DNA, RNA will be sequenced, so that we can go back to the discovery and the research arena again, if unfortunately the trial doesn't come up as positive, so that we can actually go back and work out why it worked and why it didn't work. Next one, please. So James, you can just click through this one here. So what we really want to do is that we would like, so this is probably where the clinical development on the bottom left-hand side. What we want to do is we want to profile, to enroll the patient onto the clinical trial and profile them using next generation sequencing technology to look at the DNA and RNA and to select the appropriate patients for the appropriate drug or clinical trial. James, if you don't mind, just click through as you go. Sorry, it's a bit of animation on this side. Yeah, so those are ideas so that if we can select the right patients that we think is most likely going to be beneficial for a particular type of drugs, then we will be able to actually get a much bigger signal when we come to clinical trials. Next slide, please. And the reason for that is many of the drugs that we have on the shelf at the moment are what we call targeted drugs. And what that means is unless there is for this particular target in this patient or in the tumor, then the drug is probably not going to work. And the idea there is so that we can actually upfront select or have a better idea or what the aberration of which pathway or which target that might be present or absent, then we'll be able to actually better match and able to find the right trial for the patient. Next, please. But and you can also click through this as well, James. So, but what we really want to do, and this is where the master protocol, which is the center of almost like an engine of the clinical trial part, is that we will use this as almost like as a portal so that we can actually recruit patients with either suspected or confirmed pancreas cancer. So we'll be able to screen these patients, biopsy them, do the molecular profiling of the tumor, and then we can send the patient downstream to one of the clinical trials that we have there. But if patients so do decide after molecular profile decide they want to go to standard care, we can also follow these patients up. However, most of all, what we really want to provide the patients is that we want to provide patients with multiple opportunities to participate in clinical trial. So for example, if the patient participates in one of our clinical trials that give chemotherapy before surgery, then after surgery, they can come back to a clinical trial that we're like asking the question in the setting of how does chemotherapy work after surgery? And then if the patient do, unfortunately, the disease recurs, then they can come back to our first line and second line advanced disease clinical trial as well. So basically offer, as many opportunity to as many patients as possible in every clinical setting and shot at the clinical trial. And we'll just click one forward, please, James. But what we really also want is this platform, for all the academia as well as the pharma to use and to actually create a precision medicine ecosystem for a complementary, also non-competing clinical trial landscape. And then for a platform for all to use and for especially, for pharma to buy in and start to develop drug and do clinical trials in the UK. Next, please. Won't go into much detail. So we've had reasonable success with a lot of pharma partners such as Celgene or BMS nowadays, AstraZeneca, and also other pharma, so on and so forth. So we've completed one trial already, that's 003, and we have two current trials, that's 001 and 002. And also over the next 6 to 9 months, we're going to have another 4 trials opening. Next slide, please. So we're going to hope by the end of this year, 2021, we are going to have a trial that will be suitable for patients, all patients that present in all clinical stages, all the way from stage 1 over to stage 4. And hopefully with trials that is also suitable for patients who are less well performance status as well. Next, please. So with that, I'm going to wrap up. I'd like to, most of all, actually thank all the patients and the families who has actually participated on this platform, and obviously our major funders, Cancer Research UK. Without the funding from charity, this would never take off. And also all of my colleagues who are grant recipients and participants of Precision-Panc around the UK. Next slides, please. And we've also got a lot of support by a lot of, as you say, academia and also charity and also pharma companies as well. So thanks very much for having me again. And I think we'll probably have discussion at the end, I think. Thank you.
Thank you very much, Dr. Chang. We'll be moving on to Dr. Melanie Flint now, and there'll be an option for a Q&A after she's finished her presentation. Thank you.
Thanks, James. Good morning. I really enjoyed Dr. Chang's talk. That was really good. We're going to switch gears a little bit, and James has asked me to talk about some of my own research and some of the thoughts of kind of how the pandemic has affected cancer research in general. Could I have the next slide, please? So as David said, that cancer is a disease of our cells, and we've known for a while a little bit of what happens, but there's still a lot we don't know about this. Next slide, please. So as I said, I study breast cancer, and although we're getting better at treating breast cancer, it will still affect 1 in 7 women in their lifetime. Breast cancer is a heterogeneous disease, and what I mean by that is that there's kind of, you may have heard about this, and David mentioned this also a little bit, is that within breast cancer there are different subtypes, and this depends on the type of receptors. So they may be hormone receptor positives, have the estrogen progesterone receptor, for example, have the HER2 positive, human epidermal growth factor 2 positive, and also triple negative breast cancers. And that's the cancers that we've been working on. So these are harder to treat because they don't have these hormone receptors on their surface. Next slide, please. So breast cancer, if found early, it is quite treatable. However, when breast cancer spreads, called a process called metastasis, it goes to those tricky and hard to treat places, and they include the brain, the lungs, the bone, and the liver. And obviously these are hard to get to and hard to treat. And it goes to other places as well, but these are the main places that it goes to. Next slide, please. So as Malcolm mentioned earlier, I do study stress. I have been very interested in stress from a molecular point of view. And just to kind of remind us of stress. So basically stress is something you experience when you think you really can't cope very well with a situation. And that could be a cancer diagnosis or amongst many different things. And if you see it as a mild threat, so maybe you're late for your boss or late for an interview, it's mildly challenging and you feel a little stressed, so you have your fight or flight hormones going, make you run faster to catch that bus and get to your interview on time. But if you kind of think about the situation, you know, such as a cancer diagnosis or living with cancer, then this can actually get quite overwhelming, and then you would probably feel quite a lot of stress. And the National Cancer Institute actually reports that psychological stress is a significant problem in cancer patients, with many, many patients saying that stress affects them from being sat down to say you have cancer to actually at the end, and when the clinician may say to them that you're in remission, because there's always that worry of what happens if it comes back. Next slide, please. I thought it'd be good to kind of explain what happens when we are stressed. So basically when we're stressed, we get activation in our brain, so in regions of the brain, which ultimately tell our adrenal glands to produce stress hormones. And these can include glucocorticoids such as cortisol. You may have heard of cortisol. And also catecholamines, noradrenaline, adrenaline. You may have heard of those, the fight or flight hormones. And what happens is that these stress hormones can bind to receptors. So basically they can talk to many cells in the body because they have receptors for these hormones. So your immune cells and cancer cells can have these receptors. And what happens is if stress hormones can talk to cells, then what they can do is can alter genes and proteins within those cells and actually affect cell function. Next slide, please. So when we first started doing this, and this was work that I did in Pittsburgh together with Nancy Davidson and Steffi Oosterreich, what I wanted to do first was to screen a panel of breast cancer cells. And I think we looked at about 39 breast cancer cells to see if they had these molecules on the surface which would allow them to respond to stress hormones. And as you can see here, these are all different cell types. They're all breast cancer, but they're different types of cells taken from different breast cancer patients. And what we found was almost all of them had these receptors for stress hormones. So that means that cancer cells can respond to stress. And the other thing that we did that I'm not showing here is that we also showed that these stress hormones could work. We could see them signaling within the cells. So we knew then that certainly if somebody was stressed and they had cancer, then it was likely that the stress hormones can go in, start interfering with the genes and proteins and telling the cell to do things in a negative way. Next slide, please. So what do we know that stress hormones do in cancer? And from our work and other work, we know now that stress hormones can promote cancer spread by increasing migration and invasion. And there's been a lot of work done also in ovarian cancer, which we're starting to work on, and in breast cancer, where we can see. And if you think about the slide I told you earlier, it's not that early cancer diagnosis, breast cancer, which is more treatable. When the cancer moves to hard to treat places, then that makes it difficult, obviously, for a patient to be able to recover effectively. Stress hormones can also increase blood flow to the tumour. So basically what that means is kind of allow feeding of the tumour, or the tumour to kind of break out and go to different places. And we and others have shown that the stress hormones can dampen down the immune response. We've known for a long time that stress is immunosuppressive. There's been wonderful studies for many, many years showing that when you're stressed, I don't know if there's medical students watching here, but around exam time, you may come down with a cold or flu because you've got a dampened immune response. There's been a lot of work. But the work in the context of cancer and the tumour microenvironment, so when you have cancer, you have your cancer cells, but there's also fibroblasts and there is immune cells in there, that we're beginning to understand the role of the immune system in the cancer microenvironment and also use that for therapies. And we also know that stress can dampen down the immune response. And then that's also another way that stress negatively impacts cancer. Could I have the next slide, please? So normally it would be very nice to kind of show you all down a microscope what happens. So I wanted to kind of show you an image here of what happens. So I've picked a stress hormone, cortisol. You may have heard about this. People talk about their cortisol levels when we're stressed. So on the, I don't know if you see my mouse here, but on the control slide left here, what happens is you have the nucleus, which is in blue, but the glucocorticoid receptor, so this is a stress hormone receptor, this is in green, this sits in the cytoplasm of the cell. So this is a normal cell within, this is actually a cancer cell, but it's undergoing no treatment. If you add a stress hormone, you see that this glucocorticoid receptor, this stress hormone receptor, moves to the nucleus of the cell. And what that's doing then is it can start doing something. Then it can look at change gene transcription, have different effects on inflammation and so on and so forth. But we can block this. And we have, there's one blocker that we look, and we're working with a company to look at stress hormone blockers. RU486 is one of them, and this is also in clinical trials for triple negative breast cancer, so the kind of very aggressive type of breast cancer. But this is kind of what happens. So you can see these effects down a microscope of what stress hormones can do to the cells. Can I have the next slide, please? And so what we've also been interested in, and I trained as a toxicologist many years ago, is I was very interested in how maybe stress hormones can affect chemotherapy. So there's a lot of work conducted of how stress can affect cancer progression, but also, many patients will be on different types of chemotherapy. If I can try and explain this graph to you a little bit. So here is normal cancer cells just growing with no treatment, and you can see they're viable and growing. If we add a drug, a chemotherapy drug, to the cells at a certain concentration to kind of block about half of them, you can see that they're less viable and less growing, and that's good. That's what we want chemotherapy to do. But if we also, in the same dish with our cancer cells and our chemotherapy drug, we added stress hormones, in this case we did cortisol, and then we did noradrenaline and adrenaline, we can see that those cells start to grow again. So this was one of the first indications. We've done a lot more work since this, but this is probably a better way to show it, is that the stress hormones may actually tell the cells to not die. Basically, they can switch on those signals that tell the cells not to die. So it can interfere perhaps with chemotherapy working correctly. Could I have the next slide, please? The other thing that we've been very interested in is metastasis and what happens actually, what do stress hormones do to cells? How do they tell the cells to go to spread to these hard to treat areas within the body, so the lungs, the brain and the bone and the liver? And what we did was we just did some experiments in cells. We treated the cells with stress hormones and we saw an increase. So if we look at the grey bar here, this is just cells without treatment. The black bar is if we add stress hormones to our cells, and we can see an increase in markers, certain markers here that we know that these markers, for example, vascular endothelial factor, I don't need to really go into the markers, but these are markers that kind of promote cancer spread around the body, and that stress hormones can actually do this. This is a snapshot of some of the genomics work that we've done, but it gives you an idea of how the stress can affect metastasis by binding to those stress hormone receptors on cancer cells. Could I have the next slide, please? The other thing that we're very interested in is the effects of stress hormones on the immune response in the cancer microenvironment. And as I mentioned before, we know that stress in general is immunosuppressive. But what does that mean to the cancer patient? If a cancer patient has a good immune system, for some cancers, then we know that this is good, this is beneficial. And so what we've done is what I wanted to do was to try and create models outside of a patient and see if we can really look at the role of the immune cells. So for an immune cell to work efficiently, it's got to be able to traffic to the area. So in this case, it's got to traffic to the tumor. It's also got to function in that tumor. It's got to do something. It's got to kill those tumor cells, depending on what site, bring in help from other immune cells so that can, obviously get rid of the tumor. So this is work done by a very talented PhD student in my lab, Gide Alhiti. And we also work together with Chandra, who's a mathematician, and Fengwei Yang and others actually. Fengwei Yang is a computational biologist. So basically we're working with people that can image cells, mathematicians, to try and be able to quantify how immune cells can traffic into tumors. So this is cancer cells together with immune cells without stress hormones. The cancer cells are here in green and the red cells are the immune cells. So in the control, what happens is the immune cells can go into these little mini tumors we've created outside the body and start to do their job. And eventually over time, we see that those tumors will shrink. If we add cortisol, what happens, I don't know if you can see it very well, but actually the immune cells stay on the outside. They don't really go in as well. Some do go in, but they don't go in as well. So somehow cortisol is preventing those immune cells going into the tumor. And we also know, if you remember earlier when I was talking about stress hormone receptors, so the way stress hormones talks to our cancer cells and the way that stress hormones talks to our immune cells, is that immune cells also have receptors, so it's possible that cortisol is affecting the immune cells as well as the cancer cells. But again, the good news here is that we have these stress hormone blockers, and if we have the stress hormone blockers, this is taken at a later time actually, you can see the immune cells, which are in red, within here, and they can start gradually helping the immune cells break up this kind of spheroid, these mini tumors that we've made. And so we're doing more work on this. And I wanted to highlight this work because later on, when I'm going to talk to you about what we need to do as researchers, it's really important to work together with people, within the cancer field, but also people outside the cancer field. So the mathematicians that I work with, computational biologists, they can then help me quantify this. So we can have a look by eye, but it would be really good if we can kind of put a measure on this and see what can happen. And if we can do this, then we can start at looking at different drug treatments, combinations of treatments outside the body. Could I have the next slide, please? So for the last few minutes, James had asked me to talk about the impact of the impact of the pandemic on cancer research and the future of cancer research. And I think this is really an important point. So Breast Cancer Now actually did a study, and it's on the Breast Cancer Now website. And what they found in their study was about 11,000 people in the UK could be living with breast cancer that's gone undiagnosed due to the pandemic. And in actual fact, in this study, 1.2 fewer million people had their breast cancer screening, their routine breast cancer screening between March and December. So that's a lot of people. And this is mainly due to disruption in NHS services. And then obviously there is this backlog of breast screening. And also, just as worryingly, 90,000 of these people, there's a decrease in 90,000 of referrals to specialists. I'm focusing on breast cancer here, but this is the same for other cancers as well. And we know within breast cancer and other cancers, and David spoke about this in pancreatic cancer, obviously that's one that's diagnosed late, same with ovarian cancer. When they're diagnosed later, it's harder to treat. So in the case of breast cancer then, if it's diagnosed early, it's easier to treat. But if there are delays on these diagnoses and the cancer becomes more advanced, then we need research to help us understand the disease a little bit better. Could I have the next slide, please? So I guess with the future of cancer research, what are we doing? Everybody's all getting together to kind of work really hard on this. What we still need to do is understand risk, so genetics, stress, diet, having better tests and liquid biopsies. In breast cancer, as well, we're still learning about this, but we're getting quite good at diagnosis on that now. But then after, with these diagnoses going missed and stuff, what we also need to do is we need to focus on new treatments and combined treatments. And we know that immune therapists are using our own immune system to help fight disease. There's been a lot of research on this, and there's still continued research. We still also need to fully understand the biology, so what the immune system does in cancer, and then also with the new treatments, such as there are checkpoint inhibitors, etc., that we can use, that clinicians are using to treat cancer. So for research points of view, we've got to understand this, understand the immunology of cancers, and then how we can improve on this to help improve therapies. In addition, also to understand the mechanisms of disease, how does the disease spread, to try and prevent it? Because if we can understand, again, the biology of the cancer, so how it spreads to the brain or the lungs, these hard to treat places, then the patient will have a better chance of survival. Could I have the next slide, please? So what do we need to do? And David did a fantastic introduction to this. So I think one of the top things is precision medicine, just exactly how David was talking about with pancreatic cancer. This basically tailoring medicine to individuals, and also by precision medicine this also covers risk of disease, what patients have. They may have higher risk. So David mentioned the BRCA mutations, but basically with precision medicines to tailor the treatments to predict a better patient response. And this is not easy to do. Also to work, what I think from my opinion is to work together as multidisciplinary teams, research teams, to understand how to prevent the disease, how to stop it spreading. And as I said, I've worked with mathematicians, is to work together with cancer biologists and cancer researchers, but also work with lung physiologists, or I'm working with a neuroscientist to figure out how breast cancer spreads and how it goes to the brain. How does it settle in the brain? And in particular, I'm interested in what stress has an effect on that process. So kind of working together with people outside the field as well. And also in light of this pandemic, which has had such a disruption, personally, my lab was closed from March the 21st. We managed to get it open on August 1st, and touch wood, we've kept the lab open and going. But we've got to also ensure continued funding for cancer, because it's still a significant disease affecting many people every day. And unfortunately, because of these delays in screening and delays in people not wanting to trouble their GPs and clinicians, that we still need to do more research then to help patients. Next slide, please. And these I just would like to thank both my funders on the left-hand side that have kindly funded our research. And also, this is a cancer stress lab at Brighton. These people all work many, many hours to try together to understand, in our case, breast and ovarian cancer. And next slide, please. I just would like to say thank you very much.
Thank you very much, Dr. Flint and Dr. Chang. We now have until 11 for a Q&A session if anyone has any questions. I think there are a few popping up in the Q&A section. Thank you.
Hi, good morning, everyone. I'm Nikki, the OHP co-president. I'd like to thank Dr. Chang and Dr. Flint for an insightful talk, and it's truly amazing work that you are doing. So we have 10 minutes for any questions. If you have any questions, please post them in the Q&A feature, or if you'd like to come on and ask directly, you could also do that. We already have a few questions. So this question's for Dr. Flint. You said you looked at tumor models outside of the human body. How realistic are these models to the human environment?
Well, I think that's a really good point. When you take things out of the body, what we're trying to do is to mimic it the best that we can. And so what we're hoping to do, so we're working with surgeons, so hopefully breast and then ovarian surgeons that we've set up, where we take the tissue that they normally throw away during the surgery, and then we can look. There are always limitations with every model, but I think this is really good to study mechanisms, and same with when we're studying brain models, looking at tumor slices, and what we have to do is to kind of factor in those limitations.
Thank you. Our next question is for Dr. Chang. How close are we to patient tumor sequencing to choose targeted treatments?
In fact, it's probably already happened in quite a few different cancer types already. So at least nowadays with advanced colorectal cancer, several genes is being looked at to actually select what the first line of treatment for metastatic disease is going to be. And not necessarily even tumor sequence, but with standard breast cancer, they will be typing for different hormone receptors, what Melanie said there, and also looking at if there were to be HER2 amplified as well. And also more rare cancer, so not rare, but I should say more common cancers like lung cancer, quite often they've already gone through a panel of sequencing of particular genes, I think, already. So, but I guess the next wave of revolution through the clinic will be what we call a larger gene panel. So, a panel that can look at probably roughly, 150 to 200 genes that we know they are bona fide tumor suppressor genes and oncogenes that potentially have a therapeutic sort of implications and selection reasons for doing it. I guess the trick at the moment is, not the trick, but I guess the cost is still relatively high at the moment. However, we are seeing as the technology advances that the pricing for next generation sequencing is really sort of dropping. So almost to a smaller cancer gene panel nowadays will probably be slightly cheaper than say doing 3 genes in colorectal cancer, looking at KRAS, EGFR and BRAF together. So I think obviously the clinical world is still trying to work out to iron out the workflow, but certainly, the technology is there, and we just need to make sure that they are clinical grade tests, and B, they are financially, it is a viable aspect to do so. But again, if we do give the right drug to the right patient, not to give the wrong drug to the wrong patient, then in many ways we're already saving dollars and pounds there already.
Thank you. The next question, I believe, is for Dr. Flint, and they're saying, is there any relation with pollution?
Possibly. Possibly, yes. I think you mean with cancers and pollution, yes. If it's with stress, possibly as well. But yeah, pollution can play a role.
Thank you. So the next question, Dr. Flint, if stress has a role in preventing the immune system from impacting cancer, do you believe stress may have a role in development of cancer in the first place?
So I get asked this question a lot, and we just wrote a paper on this with a psychologist and a couple of clinicians in the States to Cancer Research, where we've reviewed the literature on can stress cause cancer. In my honest opinion, I don't think stress alone can lead to cancer initiation, but I think together with something else, so a BRCA mutation, or maybe another mutation, or a viral exposure, or things like that. And when we've carefully reviewed this evidence, and particularly with the role in the immune system, we think it should be factored in. But again, I think it's with something else, because we all experience stress. And so I don't want everybody to leave from here going, I'm very stressed out, I'm going to get cancer. But I think it's a contributing factor in initiation. That's a great question.
Thank you. Dr. Chang, you mentioned that pancreatic cancer treatment incorporates discovery, preclinical development, and clinical development. Would you say any one of the elements proves more challenging than the other?
They're all challenging, to be honest. There's nothing is easy when it comes to pancreas cancer. The models are very good. The patient, unfortunately, in general, all present late, meaning that their performance status would not allow clinical trial. And even studying the molecular biology and pathology for pancreas is difficult, has traditionally been difficult, because anatomically, the organ is quite far back in the abdominal cavity, meaning that to get a biopsy or sample traditionally is difficult. So unless it's been explanted from surgery, we can't really biopsy the pancreas cancer until probably, in the last 20 years, we start to get more and more endoscopic procedure that we can start biopsying pancreas cancer. So I guess that's probably also one of the reasons why our understanding for the molecular biology and pathology of pancreas cancer is probably, slightly fallen behind as compared to other cancer types that the tissue is slightly easier to assess, such as breast cancer or melanoma, or even colorectal cancer, because with colonoscopy, we can biopsy every single patient if we want to. But I think it is actually, when I say that we haven't really reaped the benefit of the investment yet, but I think we actually have, improved a lot of our understanding. And then I think it's about how to actually bring all this in a coordinated fashion, so that we're going to make that breakthrough about this terrible disease. So, I'm a helpful person. I'm going to hope there's something good and big for pancreas cancer just around the corner.
Thank you. So the next question is for Dr. Flint. Given that stress hormone can suppress the immune system, do you think there is a role for stress hormones as therapeutic agents in autoimmune disease?
Do you know that we've thought about that, but not in that way. So the way that we thought about that is when patients are on immune therapies and may develop autoimmune diseases. I am talking to a colleague in BSMS to have a think about that, possibly. I don't know the answer to that. That's a great question, and it's certainly something that I am interested in, and certainly does make sense. It would demand. The issue is with autoimmune diseases is that they're very different and they're very complex, and so I would need a pretty good immunologist again to work with me on that to understand that. But yeah, I think it's something worth pursuing.
We have a question for Dr. Chang, and Emma would like to come on and ask live. Would you like to come on, Emma?
Hello, Dr. Chang. I was just wondering, given that we already have a well-established screening for breast cancer with mammography, are there any promising diagnostic screening tools and/or markers that you think will help with the early diagnosis of pancreatic cancer?
Thanks very much, Emma, for it's a great question. I mean, obviously, early diagnosis is the holy grail in any cancer prevention and treatment, really. Now, the challenge when it comes to early diagnosis in pancreas cancer is, well, we don't have a sensitive and specific enough test yet, whether it's a CT scan, a X-ray, or a blood test. And the reason for that is pancreas cancer, it's going to become one of the highest killers overall. But the incidence, i.e. the number of cases per year, is actually quite low. So the number of cases per year for male is I think the 10th highest, for females the 9th highest. So it's not, and the number of cases is not like breast cancer or lung cancer or colorectal or prostate. So meaning that even if we have a almost perfect test with 99.99% sensitivity and 99.99% specificity, we're still going to come up with a a large number of false positives patients. And also we don't have a confirmatory test, even we have this ideal test, we don't have a confirmatory test to say that the screening test is right or is wrong. So say for example, for breast cancer, patient will go have mammogram, and then if they were to find for something that is suspicious, then they'll go on ultrasound and then biopsy, fine needle biopsy to confirm whether it's cancer or not, and then they'll have surgery. But for pancreas cancer, there's no such tests yet. So currently the strategies that a lot of research is into is about how to select what we call patient at risk. So these will be patients, not patient, individuals that they say, for example, they carry a gene such as BRCA1, BRCA2, PALB2, or other cancer predisposing genes like TP53, so on and so forth. So we'll then to screen these patients, and then, but again, what is the best screening test? So it's a rotation between from year to year of CT scan, MRI scan, or a camera ultrasound, what we call endoscopic ultrasound, to see if there's any small lesions that can be picked up early. And the other sort of a risk group will be the patients individuals who developed sort of new onset diabetes or worsening controlled diabetes, because as you know, pancreas is both an endocrine and also exocrine organ. And pancreas cancer itself is actually diabetogenic. So one of the common presenting symptoms is that patient actually has a new diagnosis of pancreas. So I guess, anyone who sort of fits the category, who's older than 50, 55, and then they develop pancreas cancer, develop diabetes, you kind of have to think about, is there any other risk factors that this patient may contribute to this patient having pancreas cancer? But again, the dilemma and the debate there is always, diabetes is very common. New onset diabetes is very common, but pancreas cancer is not. So how do we select the right patient to send for CT scan? That's another sort of, but there's a lot of work being done, looking at other things such as serum biomarkers, even stool and urine biomarkers, and also volatile breath biomarkers as well. So there's a lot of work being done at the moment, but we just need to find something that is sensitive and specific enough to take this forward.
Do you mind if I elaborate on that question just a little bit, and then we'll move on?
Sure, of course.
Do you think there's a role for some sort of flagging or screening tool on GP systems, whereby if someone has more than 2 or 3 risk factors, they could be flagged up for further screening?
So in fact, there's already trialing this particular tool in London already. I think it's developed by UCL. So it's an electronic tool. So it's almost like screening sort of questions and when to refer patients. And then when they get to the A&E, they also have this screening tool to work out which patient specifically is going to become the alert, and then you're going to send them, for urgent CT scan or MRI scan. So that's under trial at the moment, and I'm going to be hopeful that they're going to pick up earlier stage disease. And any early pickup is good.
Thank you very much.
Thank you.
Thank you. We have a question from Dr. Chevassut, and he'd like to ask the question. So if you'd like to unmute yourself, Dr. Chevassut.
Thanks, Nagin. So I can't get my video to work for some reason, but hopefully you can hear me. So Mel and David, both fantastic talks, really brilliant. David, pancreatic cancer is such a terrible disease. It's a cancer which all doctors sort of live in fear of, themselves, because we know the prognosis is so appallingly bad. One question I had, which was, just following up from what you were saying about screening, because the mutations for pancreatic cancer are well described, there are obviously many of them. What about looking at circulating DNA or DNA in the stool, for instance, as a sort of screening test, looking for the genetic sort of hallmarks of pancreatic cancer? Because the problem is, if you pick it up by imaging, it's often too late, and even surgery then has a slim chance of success. So I just wondered if you could comment on that, and just very quickly, also in passing, just make mention of the new KRAS inhibitor that is being much talked about, and there look to be some promising results, but I didn't see it in your slides. I just wondered if you can make a mention of that as well. Thanks.
Yeah, no, absolutely, Tim. So I guess the second question is a quick one. The KRAS specific KRAS inhibitor you pointed to is KRAS G12D inhibitor that has enjoyed quite a bit of success in colorectal cancer, but that's 1% in pancreas cancer. So we have a lot of, so KRAS is almost universal in pancreas, 93, 94%, but majority is G12D, G12V, G12R, and some Q61. But G12C, we got very excited. We heard about that, and then we went back to the data. It's like 1%. Okay, that's not. Yeah, we should have it on the shelf as if we see it, but not. Yeah, not quite yet. But there are some exciting development in other KRAS inhibitors also, like you very correctly pointed out. Okay, so back to, I guess, using KRAS as a circulating biomarker. For whatever reason, especially early stage, even resectable stage, the cfDNA concentration for KRAS is really low. It's almost, for whatever reason, whether it's because it's a hepatic filtration that they filtered out, that we don't really know, but people have done side-by-side concentrations of portal venous blood versus peripheral venous blood, and the concentration of peripheral KRAS almost dropped to undetectable. So we don't have a sensitive enough test for that. What if going through, say, stool? The thing is, even the adjacent so-called non-tumorous pancreas in a setting of that has cancer next to, or very early disease, or even chronic pancreatitis, some of those will actually have KRAS mutations as well. So all they are just waiting for the second event, like a TP53 or a CDKN2A or SMAD4, then boom, they're off. So they already, as we age, we probably already carry some KRAS mutation in our pancreas and perhaps in the lung as well already.
That's fascinating.
So that, yeah.
Yeah, thanks for those answers. That's very interesting indeed, and thanks again for your talk, and Mel also.
No, thanks very much.
Thank you. We will have one more question if Professor Reed wants to ask his question.
I was actually going to ask about the screening question. So that was taken earlier, which was fantastic. I'm just going to make one observation because I know we're just running over time. And in breast cancer, where we've seen fantastic improvements in survival, and many other cancers where we've seen great improvements in survival, actually all the benefit in survival has been in the under 70-year-olds in breast cancer. There's been almost no turn on the dial for older people with cancer. And of course, we have an aging population, which will increase cancer rates. So my sort of observation is we need to find more inclusive trials for older patients because they are systematically excluded, if not on the actual criteria anymore. So we've stopped that, but we still find ways of excluding older people from cancer trials because of the comorbidities and the problems of deaths from other causes muddying the water, which is completely understandable if your focus is to prove or disprove that your new drug works. But I do hope that we'll open up trials more for older people, and pancreatic cancer, you're considered old if you're over 55 or 60, aren't you really? And it's clearly because the surgery is quite a challenge to undergo. So I hope that we can do something in that area going forward. Otherwise, we're just going to be missing a large part of the population who are affected. But I thought those were both absolutely fantastic talks. Thank you. David, you're a surgeon scientist. Mel, you're a true collaborator. Thank you.
Thank you, Professor Reed, and thank you, Dr. Flint and Dr. Chang. You delivered an excellent talk.
Thanks very much for having us.
Thank you.
We just have a 10-minute break now, so I'll put on a running slideshow, and if everyone can join us back at about 11:10 for the oncology section led by Dr. Richard Simcock. Thank you very much. And if we just give it one more minute, and I'll let Dr. Simcock introduce this next section on oncology with a clinical and patient focus. Thank you very much.
Okay, so thanks everybody. Thanks so much for the invitation to come and talk at this inaugural, I hope, seminar. I'm also very grateful to the organisers for using a photograph of me which made me at least 20 years younger, which is an absolute marvel of scientific research. So I'm older, if not wiser by now. My name is Richard Simcock. I'm a consultant clinical oncologist based at the Sussex County Hospital. I work at the Sussex Cancer Centre in Eastbourne. I also work as a consultant medical advisor for Macmillan, and a proud supporter and trustee of the Sussex Cancer Fund. And people participating in this webinar today have all given their time, knowing that as well as raising awareness, we're also raising money for the Sussex Cancer Fund, and very grateful for your attendance fees in that respect. And if you're watching this on any of the social media platforms at some later stage, I'd encourage you at least to think about making a donation to the Sussex Cancer Fund so that we can continue to support research locally here in Sussex. The start of this morning's session was very exciting. It's about frontiers of medical research, about where we might go with precision medicine, what the translational research in taking concepts from the laboratory and bringing them into clinical practice, probably many years from now as those concepts develop. What we'd like to do in this next session is talk about the research that is happening in the clinics here and now, and specifically how that research has impacted on the treatment that we're delivering here and now, because research is not something that is happening somewhere else, that is having some esoteric or distant impact on disease somewhere else. It is something that is making a difference to people's cancer treatment right now in all of the treatments that we're delivering in our cancer centres, both locally and around the world. And to give that some context, I'm very pleased that we're going to talk to Anna Potts, who I'll let introduce herself in a moment, but is a person who has lived experience of cancer, and through that experience has been part of research and has had treatments that have benefited from research. So I'll let Anna introduce herself in a moment, and then what we're going to do over the next 15 minutes or so is just talk about her experience and how cancer research directly impacted on that, and talk about what context that provides for cancer research in the UK in 2021. So I don't know if Anna could pop up on screen. Hi Anna, thank you so much.
Should be there, can you see me?
I can see you. Thank you so much for agreeing to join us to chat. Could you just introduce yourself, both in your professional role, but also your personal experience?
Yep, so my name's Anna Potts. My clinical background is that I'm a diabetes nurse specialist, and I do some work for the medical school. In terms of my personal background, I'm married, I've got 2 children, and I was diagnosed with breast cancer following finding a lump in my breast in 2018. I'm really, really glad to have been given this opportunity to come and share my experiences, because I guess what I feel I need to do is to sort of humanise research and really give it some sort of relevance and context to what it means to people like me to have that treatment, and to know that all you guys are in the background working away to try and improve outcomes, you know, quality of life and well-being. So with regards to what happened to me, I found a breast lump in 2018. I was diagnosed with a estrogen receptive, Herceptin negative breast tumour. I did have some node involvement, and my treatment was I had a partial mastectomy. I went on to have chemotherapy. I then had a lymph node clearance, and I finished everything off with some radiotherapy, and of course I have ongoing hormone treatment.
I'm very grateful to you for sharing a personal experience with us, so thank you for doing that. I'm interested that, you know, you've got a professional background, you're a healthcare professional, and just in discussing your cancer treatment there, you talked about some quite specific jargon. Even as a healthcare professional, was that jargon your jargon when you became someone who had a cancer diagnosis?
Not at all, and you know, obviously my background is diabetes nurse specialist, and so that's my language, and that made it quite difficult, I think, sometimes when you were starting to have dialogues with your healthcare professionals, because of course they didn't want to treat you as if you're a complete idiot, but actually, you know, I was starting from ground zero really in terms of understanding the language, and I was very keen to be treated like a ordinary person, you know, a non-healthcare person. Otherwise, it puts quite a lot of pressure on both the clinician, I think, and the patient.
And how did you navigate that? How did you learn the language? How were you helped in? Because if one is going to participate in research, you need to understand the questions that we're trying to answer, and you need to understand the landscape that comes from. How were you helped to understand that, or how did you help yourself to understand that?
I think it was probably a combination of having dialogue with the healthcare professionals, also getting support from some of the sort of providers like the Sussex Cancer Fund. They've got, you know, a lot of information, so you could access information quite easily, and obviously that was very readable and usable when you're coming from the point of not knowing very much, such as myself. Also, as you know, I got on the old keyboard and looked up and tried to really just give myself a basic understanding so that I could move forward and have meaningful dialogues with I guess, with my clinicians, really.
Thank you. How aware were you? What was your awareness of how cancer research had fed into the decisions that were taken with you about your care?
I think during the course of the dialogues I had with yourself with regards to my treatment, very aware actually, because I think it was very much the core of the consultation, and that was really, really important to me to understand how to best move forward in making the decisions for me. Because when you are diagnosed, you know, it makes sense, you know, so you're absolutely poleaxed. And it was really important for me to understand that the treatment I was receiving was the right treatment, and to have confidence in that and know how that had been informed by the research process. So, you know, from my perspective, I felt it was very, very much part of the consultation.
And you took part, we're grateful you took part in a small study that we were running at the time. Many women who've had breast cancer will be offered additional, what we call adjuvant therapies, as a way of reducing the risk of recurrent disease, if you like, to try and mop up any microscopic cells. And very often that's chemotherapy. And chemotherapy is something that strikes dread into the hearts of a lot of patients, perhaps because they don't understand it as well as we would like them to. But I know that one of the biggest research questions that I would like answered in my professional lifetime is, what patients could we safely avoid giving chemotherapy to? Yes. Who doesn't need chemotherapy? How can I deliver chemotherapy? And you took part in a study that was locally led by one of our colleagues, David Bloomfield, who we'll hear from later, who's using a genomic profile of the tumour called the EndoPredict study. What was your understanding of going into that study, and why did you agree to go into it?
I went into it because when I had I think it's the PREDICT model that you use initially to assess people's risk over 10 years to see if they will get, whether they'll have metastatic spread. And I was very much on the cusp of knowing whether chemotherapy was going to be of value for me in terms of the risk cost benefit. And really, because exactly for the reasons you say, the thought of having chemotherapy is absolutely frightening and overwhelming. And if I could have avoided it, I felt I would have liked to have had that opportunity. So there's this question really. And doing that test enabled us to get a clearer idea, because obviously it looks at the specific genetics of what my risk was. And it transpired that I was marginally over in the high risk group. But I think for me, although it was a hard decision, looking back, it was definitely the right decision for me to have chemotherapy, definitely.
So as it gave you the confidence to know that this thing that you didn't really want to have to do was exactly the right thing to do. And
Yes.
I'm pleased to say that that research has translated now, just in the relatively short space of time since you were part of that research. Genomic profiling of tumour has become standard practice, certainly for all node negative patients. And we've got a leading edge of further research published just in the last year, showing us that we can now rely on those tests to helpfully advise women with node positive disease. Although I have to say, not yet funded by the NHS, but high quality research is what drives political decisions. Yes. I didn't know, I thought it might be interesting. I did a quick calculation. You might be interested to know that I looked at your treatment protocol, which involved a radiotherapy decision, a chemotherapy decision, a hormone therapy decision, a surgical decision using and the EndoPredict. And without digging too deeply, I was able to quote 17 different clinical studies.
Wow.
Which led to the construction of your treatment protocol.
Wow.
I also noted that in the relatively short space of time since you finished, we have already changed those protocols.
Wow.
Now you were at the lead, I don't know, you've been taking a bisphosphonate, haven't you?
Yes, yes, still am.
Yeah, and would you like to share with the audience why you do that, or?
Yeah, because it's been shown to protect you from recurrence, local recurrence in the breast, and my understanding metastatic spread as well. And of course, it protects your bones as well, which obviously with your letrozole, your aromatase inhibitor, that can leave you at risk from that. But predominantly, it's because it's protective.
So you were one of our first cohorts of the data that demonstrated that benefit. Came in part from a large study called the Azure study, which patients in Sussex took part in. That was then analysed in a much bigger melting pot of statistical studies called a meta-analysis that was published just 6 months before we started you on that therapy. So
wow.
you're part of a leading edge of that becoming clinical practice. And then I was also looking at data that we've recently had on radiotherapy treatments now show us that the radiotherapy treatment that you had could have been shortened by up to 10 days.
Wow.
Again, that's research that women in Sussex and women nationally took part in. You took part in a very small local study, and the Sussex Cancer Fund is very keen to develop local studies for local investigators. But a lot of the information that we got to guide your treatment came from studies that are led by the National Cancer Research Institute, which Brighton actively participates in, and that radiotherapy study I mentioned took part in. As a patient, a person who's had lived experience of cancer, how do you think we as clinical professionals should engage patients in taking part in research? I just, Lance Armstrong, for all his subsequent faults, had a great mission in trying to improve the number of patients who took part in research. And he always said that he would consider his job done in terms of the Livestrong Foundation if every patient went in to see a doctor and the patient always asked the doctor, is there a clinical trial I can go and get to that point? Or what do you think we should be doing as a medical community to improve the engagement of the public with research?
I think it's a really important question, and I guess it's to be mindful as a clinician that people can change their ideas and their willingness to participate may change over time. For me, at the time of my treatment, I think to be involved in a trial around my treatment, I think I would have found really difficult. I don't think I ever shared with you that I'm a completely drug-phobic person. And if my leg was hanging off and people would say take paracetamol, I'd only usually take one. So the thought of having chemotherapy was absolutely petrifying for me. And so for me personally, at that time, with regards to treatment, I just wanted the tried and trialed type of treatment. However, that doesn't mean over time, having lived through that and survived, and and I'm functioning and doing pretty well, it doesn't mean I wouldn't necessarily change my mind. So I guess my sort of my response would be, never assume. I think you always have to ask people, because they may be at different points in their treatment continuum and their mind may change over time. So I think it's just having that dialogue as you do, really, as you do.
That's really important, isn't it? Because that uncertainty, we've talked about this before, and uncertainty is patient who's had hopefully successful cancer surgery. One of their biggest issues at that point is uncertainty about the future. And potentially asking patients to enroll in a clinical trial is asking them to embrace even further uncertainty. Can we do that in a way that provides great patients reassurance rather than
anxiety? I guess it's just about being honest and having an honest conversation with them about why it may benefit, how you may feel that the results may go forward or may transpire. And it might be that having a dialogue so that patient knows the purpose of it and perhaps some of the pre-research in order to place that in context would be really helpful. I think it's probably quite a difficult conundrum for you all at times, I'm certain. But I guess all you can do is just keep the honest dialogue going.
A bit of an unfair question because I can't possibly ask you to represent the views of every person with cancer, but how do we make certain that we ask the questions? Researchers are in the process of asking questions. How do we make sure we ask the questions that are important to patients? Now, the research question I would most like answered in my professional lifetime in breast cancer is the question that would, after a woman has had successful breast surgery, when is enough in terms of the extra therapies that we, so you will know the irony that you had a successul operation and then you let me give you a course of chemotherapy.
I didn't like you much then.
And I'm still asking you to take a hormone pill for years to come. And actually there is a possibility that none of that is necessary. So for me, as I say, if there's one question I could get answered by cancer research, it would be that. How do we engage patients in making sure that their questions are answered?
In research, you mean?
Yes.
Yeah. I think we need to think carefully about how when research is proposed, we need to think carefully about how patients are represented, I guess, on the committees that agree or decline the research going forward, and that process is rigorous in that it's not just a tokenistic gesture. It's actually people that have experience and also a range of experiences and come from a range of different backgrounds, because sometimes one is concerned that you might have somebody who may not be able to truly represent everybody, who is perhaps making decisions about research going forward and questions that are being asked. How you engage those hard to approach groups is very complex. I know.
I think we need to do more about recruiting patient voices more often.
I totally agree. And I think sometimes, Richard, it's the same people that we use for those types of things, that they may be very active, but actually we need to be asking, people that perhaps don't have a voice really to enable them to have a voice and actually help guide the research that goes forward.
I mean, you have another string to your bow, which you mentioned before at the medical school. So
I do.
You're at least partly responsible for the new generation of researchers. How can students? How should we be as educators interacting with students to improve their communications with patients about research and developing? What's the role of a medical school in both that patient interaction, but also in developing research?
Yeah, I mean, I guess that we have a really important role in engaging patients. And I think my feeling is it's so important for the students to have lots of exposure and opportunities to have patient encounters, not only in the clinical area, but obviously in the educational forum as well, so that the students can have the opportunity to have a dialogue with patients that's in a safe environment, and to be able to ask those questions, I guess, that maybe they may have felt fearful to have done in the clinical environment, because perhaps they felt that the patient had their own vulnerabilities at that point. So I guess it's about trying to ensure that the patient's voice, the lived experience, patient's narrative is really, really, really integrated into the curriculum, you know, and I think Brighton are pretty good at doing that, to be honest.
Yeah.
You know, I do think they're pretty good at doing that, because I do that job, so it's up to me to make sure that that goes well.
We're clearly biased, but I think I think it's also worth the BSMS curriculum has embedded within the IRP program,
yes,
a fundamental approach to research. So I hope that we're developing a future generation of researchers that have research methodology and research sensibilities right from the off.
Yeah, I agree.
I'm very grateful for your time. I wondered if there were any other questions from the floor. So because I'm hogging the space here. So so Jean, who I know well, Jean, who has also had a role in running research trials in the radiotherapy centre, she's asked me to ask you, what would you like to, kind of a paraphrase of question I've already asked, what would you like to see in future for breast cancer? What could cancer research deliver? What would be the ultimate holy grail for cancer research in breast cancer, do you think?
Wouldn't it be lovely that it could be prevented right from the beginning, so that we actually didn't have people having to go through that experience? I guess that is the holy grail. And perhaps we have to have a very realistic approach. You know, I think we need to be looking at perhaps improving ways of screening people, so for detection, and also all the fantastic work that people are doing at the moment, and will continue to do so in terms of the treatment, to make sure that the treatment is targeted, and that perhaps the side effects and the ramifications and the collateral damage that may happen is reduced, really, and having a focus on, you know, people's quality of life and well-being.
Yeah, I would echo all of that. I think the ounce of prevention is worth a pound of cure is holds very well.
Totally.
I have a personal interest in quality of life and what's sometimes called survivorship work, or living with and beyond cancer. And I think some of the work that goes into helping patients live full and recovered lives after cancer treatment is sometimes felt to be somewhat of a Cinderella. Today's seminar is largely positive, but I think it would be remiss of me not to point out how drastically and dreadfully cancer research funding is impacted by COVID. Depending on which figures you want to look at, but Cancer Research UK, in their worst forecasting, predict a £7.8 billion shortfall in cancer funding by 2027. And the survivorship research, which you talk about, and the living with and beyond cancer research, which I'm interested in, have always struggled to get access to research anyway. And if I have a concern about the future research landscape, it's that those areas will remain underfunded. And I think your voice echoes very well with other people who've had lived experience of cancer that I talk to about, saying that they do want research that focuses on how they recover from what they've been through.
Because actually that's the time when the real work starts. And you know, and from my perspective, and you know, this is a very visual, give you a visual idea. I feel that when you have a diagnosis, well, for me, when I had a diagnosis of cancer and went through all the treatment, I felt absolutely deconstructed as a person, you know, physically, mentally, emotionally, psychologically, socially, spiritually. Every lily that you can think of, I felt completely deconstructed. And it takes a long time to start to sort of reconstruct yourself. I remember looking at myself in the mirror and just thinking, do you know, I don't know who I am anymore. I don't know who I am. And that was really, to lose that locus of control was very, very frightening. And I think, you know, I think you're right, Richard. I think perhaps there's a big focus on the sort of sexy side of treatment, but actually some of those things that have a real impact on patients' quality of life and well-being and survivorship may be overlooked. And we need to be, you know, we need to be mindful of that.
I think that was very, what a powerful image to you're deconstructed as a person, and just touching on all of those domains of research. You know, we've talked this morning about basic science and some really exciting genomic works. We talked about but actually the psychosocial research in terms of what it means to have cancer, the existential threat. And of course, Brighton has huge pedigree in that with the work of Dame Leslie Fallowfield and Professor Val Jenkins at the Shaw C Unit. And that sort of research in terms of developing recovery programs and approaches, communication approaches to cancer are just as important.
Absolutely.
That's super exciting, sexy as you call it.
Yeah. But it's true, and you know, that's the sort of thing that can make a real difference to somebody who, you know, has experience of being diagnosed with cancer. Definitely.
I've got some questions from the audience, actually, if that's all right.
Cool.
My first question for you, Anna, is we've got one. To what extent do you feel that you had control over your treatment, and what support did you have after you'd finished your treatment?
Okay, so in terms of the control during my treatment, I would say definitely, and I would really be very strongly saying I feel that oncology is one area where patient-centered care is very much evident. So the patient is put at the centre, and the discussions, you know, I know it's an old saying, but the discussions are with the patient rather than about the patient. So I felt very much in control about my treatment choices. The difficulty for me, actually, because of where I sat on the risk profile, was making those choices. That was the hard bit. But, you know, equally, we discussed about the research and where, you know, where that placed me. And I think that that's where the art and the science of medicine comes in, because we've got the science, but actually we need the art as well from our clinicians to know how to have a meaningful conversation with their patient to help them make those discussions. And I think that definitely happened, definitely. In terms of after, I can't remember what you said now about what was the second part of that question? Sorry.
Sorry, I'll repeat it for you. How much support do you feel you received after you'd finished treatment? And I guess, what would you have liked to see?
Yeah, I did receive treatment support afterwards. I think it was very much there. It's very much there as a presence, and you can tap in as you wish. And I think that's the important thing. You know, so for me, really, I think I probably just wanted to try and get on with life, but I know that it's there. They do have very good psychological support provided by, and it comes out of the Macmillan Centre. Obviously, that's co-funded by the Sussex Cancer Fund. However, I think I probably would like to have access to more probably psychological support at this point, because actually my needs are probably different now from what they were when I was just trying to draw breath and live, you know. So I think, you know, there probably is you know, possibly an ongoing need for psychological support, perhaps a little bit down the line for people.
Thank you very much. I've got another question for you, if that's all right.
Of course.
I've got a question from Nagin saying, if you're comfortable doing so, could you please tell us a bit about your relationship with the clinicians treating you? And I guess, yeah.
How are you feeling about that, Richard? You know, I actually, you know, they're great. Of course they're great. Of course they're great. You know, I had a great surgeon. I would imagine all the surgeons are great. I had a great surgeon. I felt very confident in him. I felt very confident and involved in my decisions, in the decisions that were made with me about my treatment. I guess the only thing that I would have been to have had easier access, I think, to oncologists, the oncology department. You know, that's purely just because of, you know, just because the resources aren't there. I used to have a little laugh to myself, thinking it was a bit like trying to get an audience with the Pope, seeing Richard, but it was always really valuable to me, and very much part of also my healing process.
Thank you very much. I think Professor Reed has a question.
Can I just have a plug to pick up on Anna's point about not getting access to oncologists? There's a 22% shortfall in consultant oncologists in the UK at the moment.
Yes.
So if any undergraduates watching this are looking for a specialty to train in, come and talk to me.
Yes, absolutely second that. We need you. We need people. We need
people. I think Professor Reed had a question.
Mm-hmm.
Hi, after that shameless self-promotion from Richard. Anna, thinking about what Mel was talking about earlier about how stressful cancer is, and one of the things that strikes me is we will teach this cohort of students here all about communication, and the high level end of that will be about breaking bad news and helping people deal with the consequences. But as a patient, did you find that you were then having to break bad news to all your circle of friends and family and go over it again and go over it again, and that kind of relives it from your point of view? Can you just tell us a bit about that?
Totally. And I think that, you know, that the hardest conversation for me was telling my kids.
Yeah. Sorry, I didn't mean to press a button.
No, not at all. I just think managing other people's emotion was really hard, because actually you're just trying to manage your own.
Yeah.
But, you know, I'm really lucky because I've got a really supportive family. So
yeah. And I suppose one of the problems is the people you're telling are not trained in communication skills like the doctors are. So
totally. All they want to know is what, you know, are you going to lose your hair? That was it.
Yeah.
That was the focus of everybody. It was just, you know, we both, my husband and I, were amazed at the how people managed it. You know, friends and family managed. They found it really hard, really hard.
Did you get any of those, oh my God, what will we do without you type of responses?
No, I didn't actually. I don't know whether to be worried about that or not.
No, it's just that I've heard people say that, you know, it's all about the other person receiving your bad news sometimes.
And you used to spend your time sort of saying to people, oh, you know, oh, don't worry. Oh, it'll be all right. But actually, you were hoping that you know, that conversation might have been the other way. But you spent a lot of time reassuring other people, and that was exhausting. It was exhausting. But, you know, I think breaking bad news to your family was really hard, and telling my kids was really hard, really, really hard dialogue to have. And of course, you're not prepared for that. And you can't say everything's going to be okay, because you don't know, you know. Exactly. That's the hard thing. Yeah.
Thank you so much.
Welcome. You're welcome.
I think we have run out of time for this session, but I just wanted to say, I think your daughter Maddie's in the chat, and she just said, what did she say? She said, thank you to all the medical professionals for providing you with the care and treatment you received, and that she's very proud of you. So thank you very much, Dr. Simcock.
So welcome.
And Ms. Potts, for hosting this session. I think, especially as a student, it's been, I love it when we have the patient educators come into our teaching sessions.
Good.
Really
Keep on. Yeah, absolutely.
So thank you very much.
You're so welcome.
I think, following on from Dr. Simcock's point, if anyone's a budding oncologist, let's bombard his inbox. And I think we have a break until 12 o'clock. So we will see you again at about 12. Make sure you get some tea and a rest.
Thank you. See you. Bye.
Bye.
Anna, that was brilliant. I know my mic's on.
I hope so. I'm sorry if I choked up slightly there. I didn't want to embarrass you, but you know, suddenly it just hits you. I knew that one would.
Yeah, I'm sorry about that. It wasn't planned,
not
but
at all.
It's such a stressful thing to have to do, isn't it? To repeat that news to so many other people all the time and deal with their responses.
Yes, it is. It really is. It's really hard, and you know, it is. There's no easy way of doing it. Really, really difficult.
And you get the weird responses like, "Oh, what must you have done in a former life?" or the helpful therapies, you know. And yes. Brighton's got that, but people get that everywhere. That, you know, this is the treatment for this, or what do you think could have prevented it?
Yeah.
And the stupid things that people say.
Oh yeah,
you know, because they're shocked, aren't they? They're completely shocked as well.
And you know, when you're feeling logical, you know that it's just, you know, their inadequacies and their awkwardness in being able to communicate about it. And of course you forgive them, but sometimes people do say some absolutely wild things, wild.
Mind you, I've got quite a long list of really stupid, tactless things I've inadvertently said to patients when you're slightly off guard. And you just, God, it's awful when you do that.
I think we've all done it, you know. We've all had those moments when you can see the words coming out and you want to suck them back in and you can't. They're out there. It's too late. But I hope that was helpful.
That's brilliant.
Thank you.
You know, just
Anna, it's David Bloomfield. That was really good, and thank you. You've really set a very useful tone there.
I hope so. I hope it's been useful. I just wanted to sort of humanise it really a little bit, and just show really how important research is for the end user.
Yeah, likewise, Anna. Absolutely fantastic. Yeah, you just hit it perfectly, I thought.
Oh, thank you. That's kind. Thank you.
And Richard was all right, wasn't he? I suppose.
Yeah,
he did all right
for an amateur.
I like your comment about getting an audience with the Pope.
I never told him that one before, so I hope he's not. I hope he's not sort of too wounded.
He's still listening. He's just hiding behind his screensaver.
I'm just ordering my throne online.
It's not as bad as me and the MDT on Tuesday, anyway. Asking Lynn to get me a cup of tea and pass my wallet with my microphone still on. It's just because I was ordering stuff on Amazon Prime as well. It's like multitasking.
That's right. The hidden advantages of being in doing everything remotely. I was very impressed, Anna, that you were taking bisphosphonates. I mean, if I had asked you
orally, God, they're killing.
Yeah, I mean, I think something I see quite a lot in the clinic now is patients come to me with, and educate me sometimes on things they've read that I haven't read about or know about, results of trials and new treatments that are looking promising. And, it's quite difficult on those occasions to say, well, it's difficult to prescribe you that treatment because we can't, or it's not, standard practice or what have you. When actually, they show you, evidence that looks pretty strong. And, in their situation, you would probably feel exactly the same. And I think actually you're right. We should really allow patients or empower patients to, bring forth ideas and educate us, because I can't keep on top of everything. All the new developments out there, and some of them, are coming thick and fast at the moment. And actually, we need patients to educate us sometimes. I think some, medicine sells a bit of a sort of paternalistic culture, and we think we know everything. Frankly, we really don't. And actually, we learn a hell of a lot from patients in every which way. I think you've shown that, this morning in a fantastically sort of personal sort of, manner that you talk to us.
It's been a funny old time, but there we go. We're coming out the other end. So that's really good. It's really good.
I just had a question for you, if that's okay.
Of course.
You mentioned that one of the most difficult things was telling your family. Do you think it would have been helpful if you'd had, for example, a nurse specialist there with you to tell your family? No,
I prefer to do it just in the privacy of my own home, really. I just needed to do that in the privacy of my own home. I guess maybe, and I'm sure that I know that they can offer you advice about how to, best structure those conversations. But no one knows your own kids like you, really, and you sort of know perhaps the best way of going forward and how to tackle it. But it wasn't a nice evening, that one. But anyway,
This interval, for anyone who's still here, I will just show a video from our sponsors, the Medical Defence Union. I'll share my screen now with sound this time, you'll be pleased to know.
Hi everyone, my name is James and I'm one of the founders of SignUp. SignUp is an intelligent online revision tool that helps medical students to learn more in less time by engaging with multiple choice questions and then creating a personalised learning plan for them based on their strengths and weaknesses. We've been really excited over the last few years to be working with the Medical Defence Union to offer this as a solution to their medical students and junior doctor members across the country so that more people can benefit from what we've got to offer. Today, in this short video, we're going to be talking about one of the key revision strategies that is really central to what we do at SignUp, but it's something that you can take advantage of just in your day-to-day revision, whether you're using a different tool or whether you're studying with flashcards, just with a pen and paper. So what we're talking about is spaced learning. The core concept of this is something that's very simple and intuitive and something that you're probably just doing naturally already. So the core idea is that you're more likely to remember something for longer term and more robustly if you see it frequently. You come across a lot of different points of information every day. You can't possibly remember all of it. So one of the key ways that your brain decides how to prioritize that information is by whether it's something that it's seeing regularly, because if you're seeing it often, it must be important. So this happens naturally in the medical course because you're going to come across a particular condition, first off in a textbook, then maybe in a lecture, and then eventually you're going to see it on clinical placements as well. So attacking the same piece of knowledge in at least three different scenarios in a slightly different way is one of the ways that you're going to really build up a robust map of knowledge rather than it just being based on one thing that you read in a textbook. But it's specifically related to flashcards and MCQ-based learning that you can be doing just by yourself. There's a way that you can really use this to your advantage. So traditionally, the way that people have studied with spaced learning is to organize their flashcards or their multiple choice questions into a series of 5 boxes, whereby the first box represents things that you're struggling with, and these are the cards that you want to practice perhaps every day. Moving along to the 5th box, things that you're quite good at, and that's the box that you want to be practicing much less frequently, so perhaps just once a month. As you're going through the cards that you've got to practice, if you answer a question correctly, you want to move it back a box so that you're going to start seeing it less frequently, and it's going to be more of a challenge the next time. And conversely, if you get it wrong, then you want to bring it forward a box so that you're going to be seeing it more regularly. And then over time, the idea is that you'll be moving various cards back into the later boxes as you're getting better at them and you need more of a challenge. So that's the way that people have traditionally done spaced learning. Obviously, with mobile devices and the cloud and the internet, you don't necessarily need to manage that box anymore. So apps such as Synapse or Anki and SuperMemo will let you access content, whether it's multiple choice questions or flashcards, choose which ones you're studying that year, so perhaps focusing on the preclinical questions if you're in year 1 or year 2, and then over time, Synapse in particular sort of learns about what you're doing well and what you're not doing well, and manages those boxes for you so that all you need to do each day is just open the app and take the 10 or the 20 questions that our algorithm has determined that you most need to take that day. So just in summary, spaced learning is one of those things that is really intuitive and people sort of really understand is essentially like common sense. The more you see something, the more likely you are to remember it. But there is also a bit of theory behind it, and it's something that with minimal effort getting set up, either creating your boxes, downloading Synapse, or accessing one of the other apps, you can really start to take advantage of, and you'll start to see benefits in your revision habits and in your exams really quickly. So thanks for listening and good luck in the rest of your course.
And now I'll just show the video from our committee here at OHP that we missed earlier. The Sussex Cancer Fund have been active for over 40 years. Their work involves funding cancer research, carrying out building projects and refurbishments, and also buying patient equipment and services. I particularly like that the Sussex Cancer Fund's work ranges from the smaller scale, such as ensuring patients have access to tea, coffee, and car parking spaces, to the much larger scale, such as investing £1.6 million towards the construction of the Macmillan Horizon Centre. In 2020, as a result of the COVID-19 pandemic, income from donations for the Sussex Cancer Fund dropped by 80%. That's why now it's so important and can make such a difference to donate to this charity to help them, to help Sussex.
I've decided to support cancer research because cancer is something that's so common Many people have either had cancer themselves or know of someone who has had cancer. And cancer research is essential in providing therapies and treatments that will enable someone to just go along their journey whilst having cancer. And due to the pandemic, many charities have been hard hit by losing a lot of money that would have normally gone towards cancer research. And I think just now is such an excellent time to provide support and help out wherever we can.
They're a local charity improving care and also working on a national level, collaborating on research that could improve patient outcomes. It's also a great opportunity for medical students to get excited and involved in oncology and raise awareness of the role of the Sussex Cancer Fund, both within the medical profession and also patients.
I'm very excited about the discovery of a new type of T cells, which recognize and kill cancer cells by interacting with a molecule called MR1. This molecule is likely to present a ligand which is very specific to a distorted cancer cell metabolism. Two things which are very exciting about this discovery is one, that MR1 doesn't differ from person to person, unlike HLA, and two, that these new T cells killed many different types of cancer cells. Those two features might give us some hope for a potential universal cancer treatment in the future.
In preparation for the showcase, I had the privilege of organising a sponsorship with the MDU, and being able to support a charity such as the Sussex Cancer Fund has meant a lot to me, and I feel really grateful to be a part of this event. Thank you.
My role in this society has included promoting events to fourth years, as well as helping with the organisational aspects of events. Despite COVID, we have had a very successful year here at OHP. We have had the pleasure of inviting both local and national pioneers in the fields of oncology, haematology and palliative care. A tremendous amount of work has gone into the organisation of the Cancer Research Charity Showcase and Fundraiser. We hope you enjoy the event and encourage you to donate as much as you can to this very noble cause. Thank you.
Our events. So, our illustrious leaders, Peru and Nagin, started this society up from the ashes. This time last year, this society did not exist. They revived it, and then in September, we really hit the ground running. We had our first event with Professor Pepper talking about the clinical advances in CLL. And then we leapfrogged straight from there into the next event a few weeks later with about sickle cell disease, genetics, anthropology, and race. Exciting stuff so far. We move into the next month, and immediately we have my baby, the How to Do Research series. The first one was how to read a scientific paper, talking to current researchers, getting their insights and helping students who might have never come across research before. Now bear in mind, while these events are all going on, we've got our book club running in the background. So our first book club featured the book Being Mortal by Atul Gawande, a really great read. If you haven't already, go grab a copy and have a read. Really insightful messages in there. So by the end of that, we're close to Christmas. Yay, Christmas.
We have reached 12 o'clock, and so now I'm happy to hand over to Dr. David Bloomfield, who will introduce the third section, which is concerning the Sussex Cancer Fund.
Thank you. So thank you to all the student committee. This has been, I had high expectations of this. My expectations have been surpassed. This is a superb morning. And to think that there is an oncology, haematology and palliative care committee this active in Brighton is really phenomenal. So you've already done a lot of the work in setting the scene for what the Cancer Fund is about. We used to do a lot of building with the chemo suite. We use the conference suite, a third of the Horizon Centre. We've put in money for that. And we still do all the basics for patients. We do the teas and coffees, we do the car parking, we provide medical acupuncture for hormonal symptoms. We still do all those things you expect a local cancer charity to do, but we are looking more at the research side. We've heard this morning just how important research is. And we have immense skills and local abilities in research throughout the medical school, both University of Brighton, University of Sussex and the Trust. And it's a real pleasure to see it all coming together. So I'm a clinical oncologist. I've worked in my time across the whole patch, Worthing, Brighton, Princess Royal, Eastbourne, Hastings. It's an area which has really benefited from the medical school. And now that we've got a cancer fund which is looking and working with the committee, with the medical school, with the national research, we're going to hear just 3 minutes each, basically, from a string of researchers who are all currently or very recently funded. So I think we move on to that. And thank you everyone for spending their Saturday morning looking at this and anyone watching it again. So over to the presenters, and we're going to start off with Dr. Andrea Pepper.
Okay, thanks, David. So the sharp-eyed amongst you will note that I'm not Andrea, I'm Chris. Andrea is very lucky that she isn't me. But my job really is just as the warm-up act for Andrea and Eleni, who are going to talk to you about 2 specific projects that we're doing, which have been funded or are being funded by the Sussex Cancer Fund. So, James, can you just give me the first slide, please? Great. So Andrea and I arrived at Brighton and Sussex Medical School in 2017, in that glorious halcyon time, pre-COVID. And this is a picture of our team when we could get together and have barbecues and drink the odd beer. Hopefully those days will return. I'm ever the optimist. But when we first arrived, it literally was Andrea and myself. But you can see we've grown quite significantly, and we have plans to expand a little more in the future. But some at least of this expansion is caused or been helped by the Sussex Cancer Fund. So if you could give me the next slide, James. So this is an instrument that the Sussex Cancer Fund co-funded or matched funded with the medical school. So I'm grateful to both Malcolm as the head of school and to David as chair of the Sussex Cancer Fund for having the foresight to help us to buy this instrument. This unassuming looking piece of kit actually costs £180,000. Ouch, I hear you say. So the Sussex Cancer Fund provided £90,000 and the medical school the other 90, that allowed us to buy this piece of equipment. And it's proven its worth every single day. We use it every single day of our working lives in the lab. The picture on the right-hand side, if you just ignore the ugly fella in the background, the 3 lovely ladies from Sussex Cancer Fund, Jo, Jean, and Julia, are there in the front with Andrew, of course. And I'm going to hand over to Andrea now, who's going to talk to you about at least one example of how we use this instrument every single day to try to understand better some of the biological processes that go on in tumour cells. So over to you, Andrea.
Hi, everyone. Can I have the next slide, please? So our group are currently working on 3 hematological malignancies at the medical school: diffuse large B-cell lymphoma, acute myeloid leukemia, and chronic lymphocytic leukemia. As Chris has just said, the Cytoflex is used for all of these projects and absolutely essential to our research. What I'm going to present today is some data I've got on CLL, and so that you can see how important it is to us. Firstly, I'll just give you a rough overview of CLL. It's the most common leukemia in the Western world and is currently incurable. It's a build-up of malignant but very dysfunctional B lymphocytes in the peripheral blood, the lymph nodes, and in the bone marrow. the tumour migrates between the three compartments. It's easiest to treat when it's in the peripheral blood, but it proliferates and is far more resistant to drugs when it's in the lymph nodes. It needs absolutely to migrate to the lymph nodes in order to survive, and therefore we need to try and block that migration. And next slide, please. So what triggers a CLL cell to migrate? Well, CLL cells have receptors on their surface that when that receptor is engaged, it can trigger them to both proliferate and to migrate. The B-cell receptor is one such receptor, and inhibitors of the B-cell receptor have absolutely revolutionized treatment of CLL. But unfortunately, some patients are refractory, some develop resistance, and it's not curative. The patients can never come off the drug. Therefore, CLL cells must be activated to migrate through another pathway as well. And our theory in our team is that pathway could well be the TLR9 or toll-like receptor 9 pathway. TLR9 is triggered by free DNA in the plasma, and our hypothesis is that actually it's the patient's own DNA that's triggering this. So basically what we think possibly happens is that the CLL cells themselves break down and die. They release their own DNA, and then that DNA actually triggers live CLL cells to proliferate and to migrate. And next slide, please. So I want to show you here some evidence to try and support that hypothesis of ours. Firstly, on the left-hand side, you can see a graph, which is the white blood cell count of patients with CLL against their plasmid DNA levels. And as you can see, the higher the white cell count of the patients, the larger the amount of the plasmid DNA they have in their blood. Interestingly, it's unmethylated DNA that actually triggers TLR9 signaling. So we measured unmethylated DNA in the plasma of patients with CLL and compared it with a normal healthy controls. And you can see from the middle graph here that patients with CLL, we found out, have up to 200-fold more unmethylated DNA in their plasma than the normal age-matched controls. The third piece of evidence is on the right graph, and it's a Kaplan-Meier curve of time to first treatment. Here we divided the patients into two groups, depending on whether they had low plasma DNA, which is shown by the blue line, or high plasma DNA, which is shown by the red line. On the x-axis, we've got the percentage that remained untreated, and on the y-axis, we've got the time to first treatment. And as you can see, the patients with the lower levels of plasma DNA, which is the blue line, survive much longer without treatment than those with high levels. Have the next slide, please. So next, I'd like to show you how we use the cytoflex to identify CLL cells that will signal through TLR9 and then migrate. This is a patient with CLL cells that have been stained, patient with CLL whose cells have been stained with 7 colours. As Chris Mike mentioned earlier, our cytoflex machine can actually stain up to 21 colours. Firstly, we use the scatter properties of the cells. So the CLLs or cells can actually scatter the lasers from this instrument in different pattern, and we can use that scatter pattern to actually identify the lymphocytes. So the first plot on the left-hand side labelled A is gating of the lymphocytes depending on their scatter properties. On graph number B, we have to make sure that we're only ever looking at single cells and not doublets, which are cells that are stuck together. So again, we use the scatter properties, the forward scatter height against the forward scatter area to gate on the single cells. Then we know when we get to see that we've got the single lymphocyte population. Lymphocytes are made up of B lymphocytes and T lymphocytes, and CLL is usually, not always, but usually and malignancy of B lymphocytes. Therefore, we use CD3, which is a T lymphocyte marker, to identify the CD3 negative B lymphocytes and gate on those. Then for D, we put in a viability dye to make sure that we're only gating on the viable cells. Dead cells will pick up the viability dye and fluoresce, and so we gate on the ones that are negative for that. And then finally, for graph E, we gate on the CLL cells themselves by using CD5 antibody and the CD19 antibody. The top right-hand corner shows that the CD5 positive, CD19 positive CLL cells are the main B lymphocyte population there. And you can see just to the left of those is a scattering of normal lymphocytes, which shows how dominant the malignant clone is. Once we've gated on the CLL cells, we can then look at their expression of TLR9 and also migration markers CD38 and CD49D. I've circled in red here the CLL cells that have got the highest expression of TLR9, but also the highest levels of CD38 and CD49D. These are the CLL cells that will migrate to the lymph nodes, and these are the CLL cells that we need to block. Have the next slide, please. Next, I'd like to show you how we can block migration. CLL cells from 7 patients being put into migration chambers, and the number of cells that migrated over a 4-hour period have been counted. The bar chart is a combination of 7 patients. In the royal blue bar chart on the left, you can see the maximum migration of the CLL cells in the absence of any drug. The turquoise bar shows that the migration is reduced by inhibiting the B-cell receptor with a drug called ibrutinib. Interestingly, when we inhibited the TLR9 on its own, the migration was even less than that inhibited by the ibrutinib, and that's shown by the red bar. Finally, when we combined both ibrutinib and TLR9 inhibition, we managed to reduce the migration the most. All of the counting for this experiment was also done on the Cytoflex machine. Here's the next slide, please. This data shows you how we've used the Cytoflex to show that TLR9 inhibition is an exciting new potential therapy for CLL. This work has now been published in the top international journal for haematology, Blood. In addition, it's also led to an MRC grant for 3 years so that we can carry on looking into this work. The questions that we're going to be asking from the TLR9, from the MRC grant, is whether we can use our simple migration model to predict which patients will respond to the current therapies out there and which patients need an extra drug as well, such as TLR9 blocking. And secondly, what we want to try and do with this grant is try and find a single drug that can block both the TLR9 signaling pathway and the B-cell receptor signaling pathway with one hit. The next slide, please. Finally, I want to introduce AML before handing over to Eleni, our PhD student. We have 2 projects on AML, both of which are using the Cytoflex really heavily. AML is a disease of poor survival rates, and the immature cells are anchored into the bone marrow where, again, they're protected from the drugs. Project 1 that we've got going is a really exciting project in collaboration with a drug development company, Nucana, looking at novel drugs to try and kill the stem cell compartment. And I'll now hand you over to Eleni, who will tell you all about her project, which is Project 2.
Hello, everyone. James, can I have the next slide, please? Thank you. So firstly, I'm going to introduce myself. So my name is Eleni. I'm currently a junior doctor training to be a haematologist. I also love research, in particular laboratory research, because I find it very creative. So the bench to bedside type of research. And thankfully, the Sussex Cancer Fund has enabled me to spend 3 years in the lab to do my PhD on acute myeloid leukemia. My supervisors, you've already met them. It's Andrea Pepper, Tim Chevassut, and Chris Pepper. And basically, my project looks at how the bone marrow environment affects the leukemia cells, and how can we find new targets to improve leukemia treatments. Can I have the next slide, please? Thank you. So acute myeloid leukemia, as Andrea said, is the most common acute leukemia in adults with the lowest survival rate. It's relatively common. We have about 3,000 cases per year in the UK, and definitely its incidence is increasing since the 90s. The 5-year survival rate is quite poor at 20%, and for people over the age of 65, this can be as low as 5%. So there is a real need for better treatments. The big problem with AML is that even if the disease goes away with chemotherapy, it always comes, not always, but in most cases, it comes back, which is what we call disease relapse. Can I have the next slide, please? Thank you. So the theory behind my project is that the leukemia cells, these purple, pink dots on the figure, can move between the blood on the top in the vessels and the bone marrow on the bottom. In the bone marrow, the leukemia cells stick to other cells which protect them. So the chemotherapy goes into the patient blood, it kills the leukemia cells that are there, but it cannot reach and kill the leukemia cells that are stuck in the bone marrow. So over the years, the leukemia cells in the bone marrow grow and cause disease relapse. What I want to do is identify the mechanism by which the leukemia cell sticks to other cells in the bone marrow and develop new drugs to force them out of the bone marrow and then kill them with chemotherapy. Next slide, please. Thank you. So I have 4 aims in my project. During the first year, I'm going to focus on aim 1 and 2. Currently, I'm optimizing a 2D system that mimics the bone marrow environment. And to do this, I'm using different cell types to make it as realistic as I can. I'm going to test different drug combinations and find the best combination that detaches the leukemia cells from the bone marrow. And then later in my PhD, I'm going to optimize a 3D system now, mimicking the bone marrow, which is a lot more physiological and will actually mimic the circulation between the blood vessels and the bone marrow. Using this model, I'm going to compare the attached versus the detached leukemia cells and find novel targets from the cells that are persistently attached after all the drug treatments. Next slide, please. So these are just a few nice pictures from my experiments. You can see on the left, this is when on my 2D model, I plate the bone marrow cells. Then on day 2, I add the AML cells, and on day 3, I analyze the result. And on the right, you can see these bright dots. These are the leukemia cells, and you can see how beautifully they have stuck down on the bone marrow cells that are underneath. And a picture from further away, can I have the next slide, please? Is this one. So on the left, you can see the bone marrow cells that have grown in a plate. Then the picture in the middle is just leukemia cells on their own. And then on the picture on the right, you can see both of them together and you can see how the leukemia cells grow on top of the bone marrow cells in patches. Next slide, please. Thank you very much. I mean, I just wanted to mention that the Sussex Cancer Fund funds me to do this work, so I wouldn't have been able to do it without them. But also my project relies on the machine, the Cytoflex, the equipment that Andrea and Chris kindly mentioned before. So I owe them a lot. Thank you very much for giving me this opportunity.
Hi, everyone. That's a picture of me. I'm not sure, can you see me?
Yes, we can see you.
Yes, we've got you.
Okay, fantastic. So I haven't got any slides. I thought I would just talk a little bit about what it is I do. As a clinical haematologist, I have one foot, obviously, you know, in the hospital, on the wards where I see patients and help diagnose them and treat them for different types of blood cancer. But I also have a foot in the lab, and I work very closely with Chris and Andrea, who you've just heard from, and Eleni, obviously, who was an academic clinical fellow previously under me, and it's fantastic that we've managed to keep you, Eleni, in Brighton to carry on the important research that you're now doing as a PhD. So I have a long time interest really in acute myeloid leukemia, amongst other blood cancers. I'm also interested in CLL and collaborate with Andrew and Chris on that front. But my particular interest really is in acute myeloid leukemia. And the reason that this particular disease is one which I think, you know, deserves great focus on is largely because the treatments for AML haven't really improved, in all honesty, in about 40 years. Certainly in the time that I've been working as a consultant, the improvements we've made in survival of patients with this devastating diagnosis have been, you know, very small, and you know, and it lags behind a lot of the other blood cancers where there have been very significant developments in the last decade or two. So what we're particularly doing in my lab, which is based at the medical school and is shared really with Chris and Andrea, is to try and understand one particular type of AML, or I should say one particular type of mutation. And going back to what David said earlier about the mutations that underpin cancers, if we can understand the mutations, then we're going to be better placed to understand how best to target those mutations and improve survival in patients. And that's really the goal of the work we do. So the mutation, the gene that I'm particularly interested in is in a gene that's involved with regulation of the DNA, and more specifically, it is involved with something called methylation of the DNA. And I'm not going to go into too much detail about that, but I have here in front of me a model of DNA, and it's obviously hugely expanded in size. Your DNA is basically a whole list of letters, and the mutation that happens in this one particular gene called DNMT3A is simply a spelling mistake in your genome. It's simply one misspelt word, so to speak, in the whole of your DNA. And if I were to expand this up to represent all the DNA in your cells, it would go around the Earth twice, I figured out this morning. And it's just one mutation in one particular base which causes the problem that can lead ultimately to acute myeloid leukemia. And what we've been endeavoring to do is to identify how this particular spelling mistake, if you like, how this mutation causes leukemia, because it seems to be a very early mutation, sometimes happening decades before the leukemia ever presents itself. how does that spelling mistake cause AML years later? And at the moment, we have glimpses of how that might happen, and it seems to involve the stem cells in the bone marrow, the cells which Eleni is looking at in her project, and the expansion of those stem cells over very many years to finally, declare themselves as this terrible cancer malignancy, which we know as acute myeloid leukemia. So we have, with funding from the Sussex Cancer Fund and indeed elsewhere, made some inroads here. And I think the first significant development we made was simply to set up a repository, a bank of samples donated by patients who we were treating in Brighton, of their leukemia cells, their bone marrow cells, which we have frozen down and store at the medical school in liquid nitrogen. And those that very kind donation really from patients has been a huge gift to us in terms of research to understand more about their disease, and more in particular about this particular mutation I mentioned, the one in this particular gene. We have found, two ways of targeting this particular mutation. And this dates back to work which again was funded by the Sussex Cancer Fund about 5 years ago, in which we identified, based on work that had been published elsewhere, 2 drugs that when used together were very successful in killing the mutated leukemia cells. And this is work we published, as I say, about 5 years ago. And we moved on to other research, but it was picked up by other collaborators elsewhere in Glasgow and actually in San Diego, in California. And through collaboration with those labs and using the patient samples, the bone marrow samples that had been frozen down here in Brighton, we managed to take this work on further to the next step, so to speak. And this work has recently been published in an important journal called Nature Communications, to show that using the 2 particular drugs that we first published on, that this really can make a difference in targeting AML cells that carry the particular mutation in the DNMT3A gene. And if we can get this into the clinic, then there's great promise that this might improve outcomes in patients in the future. So that's what we're doing at the moment. That's one sort of snippet really of some of the research we're carrying out. And there are various other strands of research which we're doing alongside that, as I say, to better understand leukemia and to improve our ability to target these specific mutations. I think I've probably taken up nearly all of my time. I'll just say one final thing, just really by way of introduction to Sally and Cressida, who I think are speaking next. And that is to say that as a clinician and haematologist, and with my affiliation to the university, it's also been a privilege of mine to supervise other trainees coming through, both in haematology, as with Eleni, and also in oncology with Sally and Cressida. And I've been involved with oncology colleagues of mine in supervising their projects, and I'm looking forward to hearing what they're both going to say, because they have also done some fantastic work made possible by the Sussex Cancer Fund, and we are, hugely indebted to the generosity of the fund, and indeed the patients and relatives who have donated to the fund to allow this research to happen here in Brighton and across Sussex, where it's so enormously needed. So many thanks, and that's all I have to say for now, but very happy to answer any questions later. Thanks very much.
Thank you very much, Dr. Chevassut. I do apologise if I've got Dr. Lorimer and Dr. Appleyard the wrong way around, but I'm happy to move the slides accordingly to whoever is due to present next.
I don't really mind. I think I think Sally's due next, but I don't mind which way around we do it.
I'll just.
Why don't you carry on, Cressida? Sorry. No, you just.
Yeah,
okay.
It's my mistake.
Okay. My name's Cressida Lorimer. I'm one of the oncology registrars, and I train at Brighton and at the Royal Marsden. And I recently completed an MD that was funded, my salary was funded by the Sussex Cancer Fund. And they also funded part of my studies as well that I did as part of my MD. So I just wanted to just do a little quick chat about the work that I did as part of that. Next slide, please. So my whole MD was focusing on older patients with glioblastoma. And glioblastoma is the commonest primary malignant brain tumour, but still relatively rare in the grand scheme of things. But average age of diagnosis is about 64, and it's tending to get diagnosed more and more commonly in older patients. So the incidence is rising and it peaks in about your 70th and 80th decade. And historically, as with a lot of cancer trials, older patients were excluded from the trials. Actually, more recently in the neuro-oncology field, there have been some randomized control trials looking at treatment options for older patients with glioblastoma. So there was some work that came out of Norway and Sweden and Canada that looked at patients over the age of 65 and different regimes in terms of surgery, radiotherapy, and chemotherapy. And so there are now treatment paradigms that are in place to give options for how to treat older patients with glioblastoma. Just to clarify, older is obviously quite a subjective term, and depending on what age you are, it may well depend on how old you feel old is. Neuro-oncology patients, because of the nature of the disease, so because of the tumour being within the brain itself, tend to age more rapidly than other cancer patients as a kind of general rule. So in a lot of breast cancer or gynecological cancer studies that are looking at older patients with cancer, often their cutoffs are more like sort of 75-ish or above. But actually in neuro-oncology, because of the insult that occurs to the brain through the tumour being there, the age that tends to be used to think about older patients tends to be around 65. So my project was looking at, although we have these ways of treating patients, so we have evidence to suggest that both chemotherapy alone, radiotherapy alone, and the combination of chemo and radiotherapy together have evidence behind them to help these patients in terms of their symptom control. It was looking at how we assess who's suitable for treatment. Unfortunately, glioblastoma is a pretty devastating disease. So even in younger patients, the average prognosis is only about 18 months. And although there is a tail of patients who have long-term survival, that's only about 5% or less of the whole group. And as you can imagine, as with a lot of other diseases, with older patients, the prognosis is poorer. And there was a big study that looked at data throughout the whole of England, which showed that actually in an all-comers group for patients over the age of 70 with glioblastoma, their prognosis was only about 3 to 6 months. And so whenever we're thinking about treatments for these patients, we have to balance their quality of life and the impact we're going to make on their quality of life with regular hospital visits, daily radiotherapy, side effects of chemotherapy, compared to the hopeful improvement in their survival that we may give them. But it's very much thinking about a palliative approach and how to recognize those patients that may benefit from treatment compared to those patients who you're just going to give horrible side effects to for their remaining months of life. Next slide, please. So I took a kind of three-pronged approach. So the beginning of my study, we looked at a retrospective review, so involving patients who had been treated for glioblastoma over the previous 5 years, and that was in Brighton at the Royal Marsden Hospital in Sutton and at the Beatson Cancer Institute in Glasgow. And we looked at a number of patients and tried to see whether there was anything we could tease out from their medical history and their symptoms they presented with in order to see if any of those were prognostic for survival. So no matter what treatment those patients have been given, were there any independent factors that could assess whether they could predict for how well people could do. And part of that also included looking at their tumour specimens. So from their original surgery that they'd had, their specimens were archived, and we got approval for these to be reanalyzed as in a lab at UCL in order to see if there were any particular mutations or anything we could see within this population that might also predict for survival. And that was part funded by the Sussex Cancer Fund with matched funding from the Beats and Cancer Charity and the Institute of Cancer Research. And that showed, so the pathological analysis on first analysis didn't actually show anything particularly unusual, but we are now working with a team in Belfast at Queen's University in Belfast who are looking at doing much more detailed molecular profiling of this than we did initially at UCL, and that work is still ongoing. The retrospective review we did showed that there were certain clinical factors as to how patients presented that could independently predict for how well they did. And so we used the background of this data to then design a prospective study. So my idea was that in a lot of other oncology subtypes, so especially in breast cancer and gynecological cancer, there's a lot of interest in doing what we call geriatric assessments. So instead of the oncologists just kind of giving someone the once over and going on their gut feeling in terms of whether they feel a patient is well enough for treatment, then using a bit more of a more detailed assessment technique. A true geriatric assessment should involve a whole multidisciplinary team. And we had to balance that in terms of real life, what was available in neuro-oncology clinics at the moment. And so I designed a neuro-oncology focused geriatric assessment tool, well, a geriatric assessment screen using pre-validated tools. And we did this as a prospective feasibility study in 3 sites. So again, in Brighton, Glasgow, and the Marsden, to see whether it was possible within the time and funding constraints of a busy NHS outpatient neuro-oncology clinic to achieve a neuro-oncology assessment. And this ran for a year and was really well subscribed to. It was run by the clinical nurse specialists in each group who really kind of took it on. It was very much their project, and they recruited very well, which was very handy for me. And so we got some good results of that and showed it was definitely feasible to do a neurologically focused geriatric assessment. Although the study wasn't powered for it, there was a strong suggestion that if people had a baseline impairment in their MOCA score, so in their cognitive assessment score, so looking at how their brain was working, then that was an independent predictor for how well they did. So patients who were very impaired in terms of their cognition and their functioning, not in terms of physical functioning, but just in terms of their processing and memory, no matter how those patients were treated in terms of how aggressively or less aggressively they were treated, they tended to do more badly. And so that was written up and published, and so was the retrospective review. And then my next kind of stem of this was to look at whether we could help try and predict who was more likely to get worse toxicity from treatment. So as I said, a lot of these treatments are based around quality of life. And there are some factors you can use from a lab point of view to see who might be more sensitive to chemotherapy. So there's a genetic mutation you can look for in these patients' tumors to see whether they are more likely to respond to chemotherapy or not. But we don't have a similar way of trying to assess who might be more or less suitable for radiotherapy. And so what I was interested in is whether we could look at using pre-treatment scans, so the MRI scans that a lot of these patients have as part of their diagnosis, to see whether we can look at the normal brain on those scans. And the theory being that, say, if you have a patient who's got high blood pressure, has potentially had a mini stroke in the past, then giving them radiotherapy to the brain may make them more likely to have acute side effects, as there's a theory that some of the acute side effects from brain radiotherapy are to do with how good your normal brain is. And so what we've done is we've set up a study that's still running at the moment, and that's running at about 13 centres across the UK. And that's looking at doing one extra MRI scan before these patients start their radiotherapy. And then they fill in, so they do a cognitive assessment, a questionnaire at baseline and at 4 weeks and 8 weeks. And they also do a quality of life questionnaire as well at that stage. And we're trying to see whether there is a correlation between changes seen on their scan before treatment and an impairment in their cognition or their quality of life. And the idea being that it wouldn't, you wouldn't ever say to a patient, you can't have radiotherapy because of what your scan looks like, but it would guide you a bit more to say, if we're thinking about treatment, actually, we've looked at your scan and we can suggest that you are much more likely to feel pretty shocking with radiotherapy and maybe not get the benefit of it. And therefore, we might go down a different line in terms of treatment. So in terms of chemotherapy or best supportive care. So most of my projects have been around trying to enable clinicians and patients to have as much information as possible and as much patient-specific information. So for their specific scan or their specific genetics, to see for them what their best approach would be in terms of trying to balance side effects and treatment benefit. And so, as I said, that study is still running, and that was very kindly also funded by the Sussex Cancer Fund. And we've recruited 100 patients. We just need 20 more, and that's due to close later in this year. So that's my sort of research synopsis. So many thanks to the Sussex Cancer Fund, who provided my salary and also a lot of the startup funding for some of my studies. I wouldn't have been able to do it without them or without a lot of the patients within Sussex and their families who have been part of my studies.
Thank you very much. And Dr. Appleyard, if you're ready, I'm happy to move through your slides.
Sorry, I hadn't unmuted myself. Apologies, talking to myself. Hello, so I'm the last speaker. I'll try not to take too long. My name's Sally Appleyard, and I am similar to Cressida. I'm an oncology trainee, and I also work between Brighton and the Marsden. So this Cancer Fund had also funded my research time, which was 3 years spending time doing full-time research, and are continuing to support some ongoing studies similar to Cressida. And I think that's one of the advantages of the Cancer Fund for us, that similar to Cressida's work, we've been able to use local funding to start projects and then be able to access more funding elsewhere, because it's always easier to get funding for something when you've done some work already or when you've already got some money committed to it. So that's a really important role of the Cancer Fund in sort of what's described as pump priming these projects. It's actually worked quite well that Cressida went before me, because it, I think, demonstrates the whole spectrum of research that we do in Brighton. So there's obviously a lot of really important lab-based research, and then Cressida's research sits more within the clinical setting, so in the hospital, and a lot of my research is done within patients' homes. So I don't sit with a white coat on pipetting chemicals. I sit in people's houses and have cups of tea, which suits me very well, and it's a very enjoyable few years and a real privilege to spend time with patients and families in their own environment and get to know them in a different way than in the clinic. So my work is in bladder cancer and focusing on quality of life after treatment for bladder cancer. So bladder cancer is a relatively rare cancer. There's about 10,000 cases in the UK each year. And around half of those are invasive bladder cancer that has potential to shorten people's lives. Unfortunately, similar to some of the other cancers we discussed today, the prognosis is pretty poor. And if people have got cancer that's invasive into their bladder, then even with the best and most radical and most aggressive treatment, then at 5 years, only about half of them will still be alive. As with the other things we've talked about, it's really important to make sure that we are thinking about how people live their lives after treatment, as well as the treatment that we can offer them, so that we can make sure that we're not subjecting people to treatment that actually doesn't do them any favours. So the work I've done is looking at people who have invasive but localised bladder cancer, so cancer that we hope we can cure, and we can do that either by removing their bladder, and then people usually then pass their urine through their wall of their tummy into a bag, so a stoma bag, or they could have radiotherapy, which is X-ray treatment, and they have to come to hospital every day for 4 to 6 weeks to have this treatment. They get to keep their bladder, so they then get to continue to pass urine normally. So there are these two options, and we know that the outcomes in terms of cancer are similar between those two options. But what we don't really have a good handle on, and what there's no data at the moment, is how people feel, how they adapt, and what the changes that they experience after treatment. And some of the challenges for us as doctors and the surgeons making decisions is that, you know, we're only really able to spend time with the patients when they're having their treatment, so we have a good handle on the kind of what it's like in the immediate aftermath of treatment. But, you know, if they're well and at home in the months and years following, we don't really have an insight into how life is for them and the different impacts of treatment. Can you go on to the next slide, please? So the part of my study that fell within my MD, within my research project, was an interview study. So this was where I went and sat in people's houses and had tea and biscuits. And I spent time talking to patients, talking to their carers, so usually their spouses, and then also time talking to doctors and surgeons and specialist nurses, and really discussing with them how, so with patients and carers, what their experience was of treatment, both immediately after treatment and in the months and years that followed, and also about how they'd approach deciding between the treatment options if they were given an option between surgery and radiotherapy. It was very interesting speaking with patients and then reflecting on their experiences of treatment and how life has changed, and then being able to spend time with their spouses, which I always did on a different day, so that it wasn't all muddled together, and hearing their perspective on it. And then the sort of third angle of the clinicians and how they approach, really mainly how they think about what treatments they suggest to people. You can move on to the next slide. There's just a couple of quotes from patients. So one of the overwhelming themes that arose from the research, so when I do the interviews, they're recorded and then transcribed. I'm about to be interrupted by a child, I think, sorry. Jacob, go away, please. I'm just in the middle of something. Off you go. The patients, and then we analyse the interviews by looking at the things that patients have said and thinking both about them superficially and also at a deeper level, to think about how that all links together between different patient groups and the things that are different and similar between the patients and carers. And I think one of the main things was about people really put up with an awful lot of change and an awful lot of disruption to what they can do, because their perspective is, well, otherwise I would be dead. So that's the option, isn't it? If you've got a cancer that's going to kill you, you'll put up with a lot. And what that means is that sometimes when people come to clinic to see us, we say, how are you getting on? They say, I'm fine, thank you, because in their head they're thinking, well, otherwise I wouldn't be here. And I think that sometimes means that we as doctors and nurses aren't able to help people with things that actually we probably could improve, because people don't necessarily volunteer them. And I think without sitting in the patient's shoes and literally sitting in their houses, it's sometimes hard to explore those things. And then just move on to my last slide, please. That was the study that was in my my research project, and then that has led on to a larger study which is part funded by the Cancer Fund, but much more funded by a drug company and a radiotherapy company. So the Cancer Fund funding allowed us to access that additional funding. And this study is looking at the same question really about how people live their lives after treatment for cancer, either with surgery or radiotherapy, but using questionnaires to quantify that a bit more, but very much looking at how people feel about their symptoms and what they're able to do. And we're running this in 35 centres across the UK. We've currently got nearly 250 patients recruited, and we're expecting to complete recruitment by the end of this year. And this data, because although it's really interesting to explore in depth people's ideas and feelings by talking to them. Doctors and funders are interested in numbers primarily, and so having this questionnaire data for a large number of patients will allow us to explore better and present better arguments for changes in decision making and changes in the way we inform patients and support them. And that's everything I was going to say. I'm very sorry for the interruption, but anyway, and yeah, happy to hand back to James. Thank you.
Thank you very much, and thank you to all the researchers from the Sussex Cancer Fund. It's really highlighted the breadth of research that is undertaken. I think unless anyone has a particularly burning question, I'll just check the Q&A. We will move on to the closing words just to stick to the time. So I understand, Parun, if you're happy to say your closing words.
Thank you very much, James. Ladies and gentlemen, I take great pleasure in delivering the vote of thanks for this fantastic Cancer Research Showcase and fundraiser. I would like to take this opportunity to formally thank so many people who have been involved in setting up this event and ensuring it was a success. Firstly, I'd like to express my sincere gratitude to the Sussex Cancer Fund and their chairman, Dr. David Bloomfield, for the opportunity to support your charity with this event. You have provided us as a student society a truly unique opportunity to collaborate with a local cancer charity that provides support for cancer patients on so many different fronts. It has been a real pleasure to work with your team, including Miss Joanna Godden and Miss Julia Lenton. I hope whilst in these strange times we were not able to meet in person, this event will act as an auspicious beginning for a long and happy relationship between the Sussex Cancer Fund and Brighton and Sussex Medical School's students and the OHP Society. And like many of the panelists have said, I hope we can continue this event as an annual billing. I would like to pay tribute to our medical school dean, Professor Malcolm Reed, who has been an unwavering source of support and guidance this entire year for steering us in the correct direction with this event, as well as introducing us to the Sussex Cancer Fund. Next, I'd like to thank our fabulous speakers for some truly inspirational and uplifting talks that exposed us to the long journey from donation to innovation. We started the day off with Dr. David Chang and Dr. Melanie Flint, whose birthday it is today, providing a superb insight into the trials and tribulations of cancer research. You have my utmost respect and admiration for the groundbreaking work you do for the betterment of cancer therapies and improving patients' lives. This was followed by a clinical oncologist whose name is very well known in the local Sussex region. Dr. Richard Simcock, you have a reputation for clinical excellence and being a passionate advocate for your patients. This shone through during your talk today. I would also like to express my sincere thanks for our patient speaker, Miss Anna Potts, for sharing some deeply moving details about your experience of cancer care. It truly places into perspective and humanizes the clinical elements, which can appear rather complex and grey, and this is all clarified when we hear from patient experiences. Thank you so much. I would also like to thank the Sussex Cancer Fund's fabulous researchers who provided a whistle-stop tour about the groundbreaking research encompassing the biopsychosocial elements of cancer care, taking place right here in Sussex and at BSMS. Dr. Andrea Pepper, Professor Chris Pepper, who launched our inaugural society event back in October, Dr. Tim Chevassut, our faculty patron of the society, Dr. Eleni Ladikou, Dr. Sally Appleyard, and Dr. Cressida Lorimer. You have my utmost thanks and appreciation for the work you do to help patients in both Sussex and nationally through your intricate collaboration networks. I would also like to thank the University of Sussex's IT department, in particular Mr. Steve Easty, for ensuring our webinar worked without a hitch today. Furthermore, I'd like to pay tribute to my fabulous OHP committee who have done so much work in the background to make this event happen. In particular, I'd like to thank Laura O'Meliway for producing our terrific posters and Instagram posts, Nagin Dara, whose birthday it is also today, and Emma Taylor Gallardo for moderating our Q&A sessions. Whilst a team is crucial for making an event a success, there is always one person who is an initiator, one person with the ideas, and that man is James Sloven. I am fortunate to call him a very good friend, but BSMS is even more fortunate to have him as a student within its ranks. He has given his all to make this event a reality today, and it has been an absolute pleasure to work with him in delivering this showcase. Finally, I'd like to thank our supporters and local businesses who promoted this event far and wide, In particular, I thank the MDU, who are our sponsors and supported this event by pledging £1 per attendee, which we as a society wish to donate to the Sussex Cancer Fund. As a reminder, you gain free access and an Oxford handbook as a student member of the MDU. And with that, I will hand over to Professor Reid, who will add to our closing words.
Thanks very much, Puru. I'm absolutely confident that you could host the Oscars one of these years. That was a brilliant vote of thanks. And I just wanted to add my thanks as well, but not to repeat everything, but particularly to thank those of you who have attended, our students and colleagues who've not been on the panel or participating. I really hope you've enjoyed this morning. And as I reflect, the improvements we've seen in cancer over the last 4 decades since I qualified, where breast cancer survival has pretty well doubled, as we were saying earlier. It'd be wonderful if some of you go on to be the clinicians and researchers that can deliver the same transformation in outcomes in the diseases we've talked about, the glioblastomas, the acute myeloid leukemia, pancreatic cancer, bladder cancer, and other cancers where we're struggling to get the improvements that we've seen in some things. And we know it can be done because we've started to see it happening in things like myeloma, in things like melanoma, which until quite recently have been really, really very difficult. But through research, exploring the pathways of these diseases, we can design the drugs and the strategies to deliver the change. And as Richard says, hopefully to also identify which patients will benefit and when enough is enough, when the benefit has been gained. And adding to that, I think the really valuable insights into the quality of life that we've heard this morning, both from the patient perspective and from Sally and others doing really first-rate work to explore this. So cancer is one of the few diseases where we always set out to reach the holy grail, which is cure, which if you think about it, we don't expect to do in other disorders like diabetes, asthma, many others. We're just modifying life to make those disorders have as little impact as possible. So as well as trying to cure cancer, we need to try and make sure that we help patients have the best possible quality of life afterwards with the fewest possible side effects from the way we use our drugs. So hopefully some of you will be inspired to take that forward over the coming decades. Particularly want to thank myself, Sussex Cancer Fund. I think they're doing a remarkable job locally and having impact nationally through this research program, which I think is just outstanding. But mostly I just wanted to thank Puru, Nagin, James and the entire panel for I think what has been an absolutely outstanding inaugural conference. And I hope that everyone has enjoyed it as much as I have done.